Okay, welcome to everybody who's joining us for this webinar presentation. This is actually the second presentation that we had today. Dr. Robert Mickley presented earlier today on implants for life, different strategies on ensuring the long-lasting life of implants to the best of our abilities. If you missed the presentation, go ahead and check out the recording on blueskyplan.com/webinars 2020. And that's really the key address to see all the recorded webinar presentations. So again, that's blueskyplan.com, webinars 2020. I am Michael Saltzman, and I'm the Director of Digital Products at Blue Sky Bio. We are continuing our viral dental education webinar series. And again, if you've missed any of those, then go to blueskyplan.com/webinars 2020. If you're watching the presentation live, then we'll be sending you the CE credit directly to your inbox. And if you're watching the recording, then after watching the recording, please look for the link on the same web address and the same site. Look for the link for the 10-question multiple choice test. Complete the 10-question multiple choice test, and we'll be able to send you the CE credit. And again, that's if you're watching the recording only. If you're watching live, then you don't need to do anything. We'll send you the credit directly to your inbox. If you have any questions during the webinar presentation, please enter them into the question and answer box. We have the privilege again hearing from the one and only Dr. Cory Glenn, the dental MacGyver educator, international speaker, runs a training center in his own hometown. Hopefully that will be up and running again in the near future after this Corona period passes. And of course, an integral and key part of the Blue Sky Bio clinical team, both on the digital side and on the physical product design side as well. Today, he'll be presenting on the topic of bone-supported surgical guides and prosthetics in-house. Cory?
All right, well, very good. Let me go ahead and share my screen.
Yep, there we go.
All right, great. Well, thanks for the introduction, and yep, appreciate you all joining in to watch this. This is, probably one of the most complex things to teach, and so if this gets down into the weeds a bit, then hopefully you'll understand this. These are, again, just complex cases. You got to use lots of tools at your disposal to pull them off, but if you'll go through the learning curve to learn this, you'll essentially be able to carry out the equivalent of what some of the other commercial options are that maybe cost $2,000, $3,000, $4,000, some of them $5,000, $6,000. And you can do that entirely yourself. And it may not be the exact same product, but in principle, what it'll allow you to accomplish is the same. So again, we'll talk about the bone reduction guides, the guided implant placement guides, and then going ahead and having a prosthetic made ahead of time that you'll be able to pick up during surgery. So we'll jump right into it. This is the big picture of what we're going to be accomplishing. I'll talk about the dual scan protocol, how to gather all your diagnostic data, how to go about planning your implants, deciding which type of prosthesis that you're going to use, how to make the bone reduction guide, and then how to make the osteotomy guide and the prosthetic. So just real quickly, this is a figure out of that I got offline, and it just illustrates that as a patient loses their teeth and begins to resorb their jaws, this is kind of how the jaw is going to resorb. So the mandible tends to resorb downward and forward, and so they get a more pronounced chin. You know, the ridge is usually posterior to the chin button. And then on the maxilla, they're generally going to resorb upward and backward. And that will heavily influence the available bone where you can put implants, and thus that's going to dictate really how, what kind of prosthesis you'll be able to make. These are a couple of images out of Dr. Mish's book, who's kind of the guy who classified all this and really laid the foundation for implant dentistry. But he breaks these into, for fixed prosthetics, for fixed full arch prosthetics, he breaks them down into FP1, FP2, and FP3. And you can see this little illustration over here, but we'll go through these one by one because the space requirements are going to be different for whichever prosthesis type you choose. And so if we go by the Mish classification, an FP1 is going to be a restoration that pretty much is only replacing the teeth, the crowns of the teeth. Okay, so in order to accomplish this, obviously you're going to have a minimal loss of bone and soft tissue. The usual expected space requirements are about 9 to 12 millimeters. You could cheat a little bit either way on that, but you could imagine if you started trying to make a 15 millimeter tooth here on a custom abutment, they're just going to look like big banana teeth. So you probably would want to go with a different option, something more like a hybrid. These are also the most demanding cases to carry out because the precision with which you've got to position your implants and then place them, it just has to be dead on so that your custom abutment ends up within the restoration. Because again, we're talking about just general crown and bridge. So you don't have these huge flanges or a huge bunch of acrylic that can cover up screw holes and that kind of thing. And these can be screw retained or cemented. On the bottom, you're seeing a case I did where we did 6 abutments and then just 3 individual bridges and cemented that on. So this would be an example of an FP1 prosthetic. This is the one probably patients like the most when it's an option, but again, it is the most difficult to carry out. An FP2 is going to replace the crown and a portion of the root or gingiva. Okay, so these are the people who've maybe been in a denture for a few years, didn't have a whole lot of perio, but there has been some bone loss. And so this one's going to be replacing the crown and a portion of the gingiva. And we're usually looking at about 12 to 15 millimeters of space. You'll obviously have a longer crown to root ratio. And again, these can be cemented or screw retained. And then finally, we've got the FP3, and this is what you would normally think of as a hybrid. So you're replacing the crowns and a pretty significant portion of the roots and gingiva. And so this is going to be with patients who have either had a lot of resorption or due to how you're going to have to place the implants or where the bone is available, you're going to have to maybe do some bone reduction. So usually with these, we're going to talk about 15 to 18 millimeters of space requirements. I mean, the dentist wants to give 10 millimeters, the lab wants 24 millimeters. So you meet in the middle there, it's about 15 to 18. And these usually are screw retained. Typically if you think about a hybrid, I suppose you could do like a telescopic type restoration, but usually these are screw retained. And so just to do a very, very brief review of Blue Sky Plan, if you're making a typical tooth-borne guide, you're just going to have your cone beam data and an STL model. You'll be able to merge those because these teeth show up in both of those scans and you'll be able to merge them properly. And then once they're merged, you can actually do your prosthetic planning based on where the teeth belong using your STL. But then you could come back and do your surgical planning based on where is the available bone and where are the prosthetic teeth that I want to emerge through. So once you position your implants, you turn on the tube, you design the guide, and then you take this guide and you're just going to set it on the teeth and do your surgery. Okay, so this is an example of that. It's a little different when we start doing full arches though, especially when the patient is edentulous, because we don't really have that common data between the teeth in both scans. You can imagine when you take a cone beam scan, all you're seeing is the hard tissue. And when you take a STL of an edentulous jaw, all you're seeing is soft tissue. So we have to go about importing all that diagnostic information in a bit different way. So regardless of whether you're doing a soft tissue supported guide, a bone supported guide, for any edentulous case, the starting point is always to do a dual scan in an ideal denture. And it is important that it be an ideal denture because, if you take their really broken down denture that's worn and collapsed and, teeth maybe not in the right position, you don't want to plan backwards from that, right? You want to plan backwards from the ideal. Okay, so this is what's going to give us the information of where the teeth belong. And you should never plan implants, in my opinion, without knowing that information of where the teeth belong. Can you get away with it? Yeah, I mean, frankly, most cases in the world are done this way every day. But then you have to go through a lot of prosthetic hoops to make the screw holes be in the right position. There tends to be more lab work, more expense. And it's just a better option all around if you know where the teeth belong and then plan your implants to exactly those positions. So we always start with the end in mind with any kind of complex case, whether it's crown and bridge or implants. And for an edentulous patient, that means if they come to you and they don't have a denture, then you need to start by making a denture. This was an old case, so did the setup. We got them in her mouth. We figured out, what the teeth needed to look like. And this was the initial try in the bottom middle picture. And to me, the buccal corridor needs to be filled out. And so we were able to expand that a little bit. And then we got her in this denture that she was happy with. And once we knew we had that, now we can go ahead and do the dual scan protocol and gain all our diagnostic information. Now, I realize that's a tough sell for a patient to come to you and they're maybe considering doing this very expensive case with you, and your answer to them is, well, I can't really tell you until you spend, you know, $2,000 on a set of dentures, right? So that would kill a lot of cases on the front end. In the old days, what I would do is just do the denture at my cost and you know, just roll it into the case fee. And I was just trying to remove the cost as a barrier, so that the patient would go through with treatment. At times I would even eat the denture cost. But now there's no reason to do that. You can actually, if you just take some models and a vertical dimension bite, you can actually design the denture by yourself. It doesn't have to be a fully processed denture. An acrylic denture, a printed denture would be perfectly fine for this purpose. And so I would suggest looking into the Blue Sky Bio denture module, and you can make them a printed denture that they can test drive, figure out the occlusion and phonetics and aesthetics and all of those things. And really your only cost is going to be the export fee and then the cost of the resin to print it. And the nice thing there is that, one, the turnaround time is so much faster. The cost is lower, and two, you can tweak this as many times as you want. You know, as soon as you start having to move teeth on a wax setup, that turns for me into a 45-minute appointment. I'd rather not do that. You know, if I print one and I don't like the way it looks, I'll just take a picture, make notes of what I want to change, and then just open back up that denture case in Blue Sky Plan, make those changes, and print them another one. It costs virtually nothing. And so I think that's a great way to do these cases. So let's say you've got now your ideal denture, and that again could be in the form of a denture they already have, a new denture that you've made them, or a new denture that is 3D printed. Any of them will work, but the point is it does need to be ideal. And so what we'll do in a dual scan is that we're going to put some radiographic markers on that denture. I usually put about 3 to 4 around the buccal flange, and then maybe 3 on the palatal or the lingual surface. That tends to be plenty enough to do this. And I would suggest getting some of these cone beam markers. These are some that Blue Sky sells. You'll see if you do this for a while that, you know, you could use flowable composite, you could drill holes and put in gutta percha. The problem with those, though, is that they're really irregular in shape once you get them in there. And the software, when you're importing the scan of the denture, is going to have a lot more trouble matching things up. These cone beam markers here consist of just like a 1 millimeter spherical glass bead, and it shows up really distinctly. It's small, and smaller is better actually in this technique. And it tends to just auto stitch very nicely. So I like these, they're convenient. They're already on a sticker and you just pop them off and stick them onto the denture. Okay, so let's say you've got 6 or 7 of the radiographic markers on your denture. You're ready to do your scan. Again, make sure that the fit is really good, because your guide, if you're going to do a soft tissue guide, your guide will never fit any better than the denture did at the time of scanning. So if they come to you and they got an acceptable denture, but it's a little sloppy, just reline that prior to doing this dual scan so that you have the tightest fit and the most accuracy possible. And then this is one other thing that I really recommend on these full arch cases. If you think about a dentate case, you always want to scan them with their teeth apart, because otherwise they all get, you know, they're touching together and it makes the stitching much more difficult. However, in a full arch case, my preference is always to scan them in complete occlusion, and I want them at that desired final VDO. So if you've made them an ideal set of dentures, they should be in that desired VDO. But I'm not going to use a bite fork. I'm going to use a chin rest in the cone beam machine and just put them in there and have them just lightly squeezing into occlusion, and then cone beam scan them, make sure they stay real still during that scan. And the reason that I do that, and this will become more evident later in the procedure or in this presentation, is because the occlusion, when you're trying to design this immediate load prosthetic, if you've got their teeth apart, well, then when I go to build, let's say, the lower prosthesis, I don't have the teeth to set the opposing against. So the best that I'll be able to do is to turn on their denture scan appliance and then try to just set some new teeth that match up to that. And that works, and it'll be pretty darn close, but you can't dial it in as much as if you did this with the patient in full occlusion. So if you don't do it, it's not the end of the world, but I do prefer that. This is what I was talking about. When you scan a patient like this, and now imagine that we're going to make a bone-supported prosthesis for the lower. Well, the best I can do is go into the Blue Sky denture module and set teeth that pretty much align to this lower arch, but I'm not in occlusion to this top. So I'm going to have to do more grinding and equilibrating to get their bite in the right position. Okay, and this again is just illustrating that because I can't set these teeth right against that upper denture, what you're seeing on the left-hand side is just, bringing the tooth chain in and setting it right to their denture, okay? And you really want to avoid using bite forks when you're doing a dual scan. This is a case that someone sent me at one point and they were about to do the surgery. And I said, oh gosh, you don't need to go forward with this because look at the back of your denture. It's pretty clear that this patient was cone beam scanned using a bite fork, and they had this huge class 2 bite, if you look on the bottom right. And as a result, it tipped the denture forward, unseated in the back, and the surgery is now going to be off by however much that denture was out of place. So don't use a bite fork. I really stress that. Use a chin rest. If your cone beam machine does not have a chin rest, I'm sure they have one available. And if there's not one available from your manufacturer, we could design you one pretty easily just using Mesh Mixer and then print it. But that's an important component to this. So you're going to take your patient, you're going to put the dentures with scan appliance markers on them in their mouth, close them into full occlusion. You're going to use the chin rest, and you're going to cone beam scan the patient wearing those dentures, or it could just be one denture. Once you've done that, this is why it's called a dual scan, is because now you'll take those dentures out of their mouth and scan the dentures by themselves. So if you just were doing one denture, you'd have one additional scan. If you had upper and lower, there would actually be 3 scans involved in this. Scan of the patient wearing them, scan of the upper denture, scan of the lower denture. Okay, now the radiographic markers are in the same place in all those scans, and that's what the software is going to use to stitch all of this together. So I opted to go with how I'm teaching this, just using screenshots. I've got videos of this stuff online already, and I thought perhaps it'd be better to just create you a cookbook where I just do screenshots of literally every single step here. So you'll be able to refer back to this and see the narrative of what we're doing and why we're doing it. So when you open Blue Sky Plan initially, you're going to tell it you're doing a surgical guide, and then this window is going to pop up. And, usually if I'm doing a 1 or 2 implant case, I'll just choose this far left option. But for a full arch case, I'm going to just choose the middle option to import the patient's CT scan. Okay. So that's going to be the one of them wearing the dentures. So we open that, you see that the software has rendered it. You obviously can't see the dentures, but you can see these radiographic markers sticking out. You can see them right here in this cross section. You can see them floating in the 3D window. And then once you've done that, it's automatically going to bring up a prompt and ask you to import additional surfaces. And so if you look, the bottom option says import a CT scan of a denture or scan appliance. And that's exactly what we want to do. And so I'm going to choose that option, and it will take you to this box. Go ahead and find where you've saved the DICOMs of the individual denture scans. And you'll just go ahead and pull that in. And the window will come up that allows you to limit your field of view. The next window is going to be your scan appliance stitching window. And hopefully this happens automatically. Okay, this is what I was talking about, that the software is able to really easily recognize those particular radiographic markers. And usually if you use those, you're not going to have to do a thing in this portion of it, because the software will automatically stitch everything. Because what it's looking for is the in the patient scan, which is your upper left, the software lowers the density so that only these radiographic markers are showing. You notice that the bone has disappeared. We don't see anything else, just a bunch of markers. Now the upper right, that is the scan of the denture. Again, the software lowers the density until just the markers are standing out. And then it's going to analyze and it's going to try to match those up. And when it finds the common radiographic markers, it will automatically stitch them. And you'll know that it did that correctly if you look in this bottom right window and if you see those red and white dots overlaying one another really accurately. Excuse me. It's allergy season here in Tennessee, so I'm struggling a little bit. I don't have COVID. And then, excuse me, finally on the bottom left, you're going to have the 3D rendering of the denture, and this should just look like an STL of the denture. So assuming that everything's stitched properly, automatically, all you'll have to do is hit OK here. Again, to know whether it did or not, you're looking for these red and white dots to overlay one another. If it doesn't, there is a way to come down here and stitch these. So you would do this like the old school way of stitching. You would hold Shift, click on that point, and find the same point over here, Shift, click a point there. And you would try to find 4 or 5 common radiographic markers and then apply it, and it will stitch it manually that way. So what's going to happen once you click OK is that the denture is going to be turned into an STL, and it gets imported into the case in the proper position. Again, it just does that based on the radiographic markers. So now we can see this denture in the bottom left window. We can see its outline by turning on the hint, which is up here in the surfaces panel. If you look in the top right, you see there's the visibility that turns the visibility of this model on and off. And then there's the hint. The hint is this model outline so that you can see where that denture is in all of the 2D views. So once you've done that, you can go to the panels and then choose the surfaces panel. And this is where you'll be able to change the color of the denture. You know, it imports by default as a white color, which looks just like the bone. So I usually will change the color to something else, make sure that the hint is on. And then you can go and import the second denture scan if in fact it's a 2 denture case or a dual arch. And so if we wanted to import a second denture, we go up to the file menu, import DICOMs, because remember this is a cone beam scan of a denture, and we're going to choose a scan appliance. Okay, so if it's got radiographic markers on it, just go ahead and call it a scan appliance. And we go through the same process now for the upper denture. And now you see that we've got the upper and the lower dentures in occlusion. I'm sorry, not in occlusion, into the case. I did not scan this patient in occlusion. This is an older case, and I didn't really understand the value in scanning them in occlusion until we started doing a whole lot of these later on. And so, you know, ignore the fact that this is in an open bite. That is not ideal. You should have them in full occlusion. And you can confirm the accuracy of that stitch by looking at the model outline. And again, you're not going to necessarily be able to make out where the denture is because acrylic shows up as about the same density as soft tissue. However, if you do find some air gaps show up as black, and you should be able to see that model outline corresponding exactly to the denture. And then furthermore, if you zoom way in right on top of one of those radiographic markers, you should see that model outline going up and around that. So now that we've got our dentures imported into the case, these are our ideal dentures. Those are where we want the teeth. And so now we can go ahead and go to the implant planning stage, and we'll begin planning our implants. So I would suggest if you're doing one of these cases to work in advanced mode. So you can go to surgical guide, but it's going to default you to the normal mode, and you won't have quite as much flexibility and as many tools available to you. So switch over to advanced mode. Any questions real quick before I jump into the implant planning?
Yeah, there are 2 questions that came in. You want to pull them up, or I could read them out.
Yeah. Okay. Yeah, I got them here. So Paul Springs says, if the patient has a well-fitting denture with porcelain teeth, do we need to use the fiducials? You may not have to, but I would still do them. I mean, they're really cheap, and I'd rather do it and not need it. But yes, more than likely, porcelain generally shows up as about the same density as a natural tooth does. So chances are that, yes, you could stitch just based on that. But I'd still put them on there just to be careful, because what you don't want to do is for it to not work out and now have to radiate your patient again. So what about using cotton rolls to remove the soft tissue? Yes, that's a great idea, not just for these full arches, but on all cases. Because like, think about a dentate case where they've got metal on every tooth. You know, you might have so much scatter on the teeth themselves that you can't stitch based on that. But if you do have the soft tissue outlines, then you might, if you see that air gap, you might be able to align your STLs just based on that, that soft tissue outline, or in the case of a denture, on the outline of that denture where it goes from the the light gray that kind of looks like soft tissue over to the black, which is just the airspace. So yes, that's a great idea. Do I need cone beam scan for the denture and a 3D scan of the denture? No, you only have to have a cone beam scan of the denture. You could add a 3D scan, like if you took your intraoral scanner and scanned it in its entirety, you could do that. I generally don't find that to be necessary though. And where do you place the markers and how many? If you look on this case in the bottom right where you can see those, you'll see I've got one way back here on the flange, another toward the front in the flange, and the same on this side. And then I've got 3 on the lingual or 3 on the palatal. That's my normal setup of how many I'm going to do. Will the cookbook be available for download or print? Yeah, I'm happy to share that. What are the advantages for doing a CBCT biting? One, because you're not on a bite fork, so you're not going to have the tendency to tip the denture down in the back when they're biting on a bite fork, because remember, this is not teeth. This thing is mobile and it's going to tilt down like in that image I showed earlier. But secondly, it's going to allow you to plan your occlusion on your immediate load prosthesis. So that'll become more evident as we go along. Works the same way with STL files as with denture DICOMs. I'm not sure exactly what the question is there. If you want to clarify, I'll try to come back to it. Do we need cotton rolls? Yes, it's helpful. What's more accurate, an STL or a CBCT of a denture? An STL is always going to be cleaner data because, like, if you look at this denture down here, it's very dimensionally accurate, but you'll notice that there's been a significant loss of detail. And the reason for that is that the biggest, the smallest detail that a cone beam can reproduce is whatever the voxel size is of that cone beam. So I don't know what most of them are. Let's say it's 100 micron voxel size, right? So voxel is just the equivalent of, like in a 2D picture, what a pixel is. So if your voxel size is 100 microns, that means it can't reproduce a detail that's 20 microns. So an STL, on the other hand, is very, very detailed because it's picking up down to 7-8 micron accuracy. And so does that matter in just dentures? Probably not. You could probably just do this with a cone beam scan of the denture. But if you're looking for the most optically clean one, especially if you're trying to do it as a prosthesis, then yes, I would do an STL scan. Do you find using a surface scanner works better for aesthetics versus DICOM? Again, I'm only using this as a planning tool. So all it's showing me is the teeth. I'm not necessarily going to use that as my prosthesis, so I don't worry that much about the detail. If we're not doing an immediate load, does it matter if they are biting on a fork or not? Yes, because still the tendency, if you're biting on a fork with a removable appliance, is that it's going to tip it. And it's critical for these things that they be fully seated when you're doing it. All right, so I think that's all the questions for right now. And I'll try to just stop and do those periodically. So we've got our dentures in. We've now changed over to implant planning for the surgical guide, and we're working in advanced mode. So if you've not worked in advanced mode, I do have some videos on YouTube of that. And I've got videos of this entire process as well if you want to review those. So once you have your implants in place, you need to plan those backwards from your prosthetic, right? So we're not necessarily just interested in getting implants into bone. I mean, anyone can do that. We're interested in them being in bone and at the right position and having the right emergence. So that's very easy to do because now that I've got this model outline, I can go ahead and drop in an implant. My typical workflow is I'm going to drop one in and I'm going to drag it back towards the mental foramen until it gives me that warning sign that tells me I'm violating the 2 millimeter safety zone from a nerve. And then I'll just back off of it until that exclamation point or that warning disappears. And that lets me know that I'm safe, a safe distance away from the nerve. And I'm going to evaluate where the emergence position is on that. And then usually what I'll do is just duplicate that implant. So if I had one implant here, I'd hit right click, duplicate, and I would take that duplicate implant and drag it over and do the same thing to this nerve. Get it as close as I can without violating my zone of safety, and then duplicate a couple more and put them in here. And that's when you can then change over and start fine tuning the positioning. And so I usually do the fine tuning of my implant positioning up here in the tangential window, because I can spin that implant on its axis. And what I'm looking to do is make sure that my implants are in the right position for the prosthesis. So if I'm doing an overdenture, then I don't necessarily care about coming out exactly under the tooth. I'm more concerned about parallelism, okay? And in making sure that I emerge in enough acrylic so that there's room for the housing. I don't know about y'all, but there's a few patients in my history where I just placed the implants freehand, and then when it came time to do the pickup, I had to drill holes in the lingual of my denture, and they ended up with this lingual denture tumor. And you got to, pretend like that's what you meant to do. So we don't want to make lingual denture tumors. We want to make sure that they're in the bulk of acrylic. If you're doing a FP1 crown and bridge, well, now if you know where the teeth belong, you need to put those those implants exactly under the teeth, or at least under the cingulums, because otherwise you're going to have to make some crazy shaped tooth and abutment to be able to get to your implant and to connect everything. If I'm doing a FP3 or a hybrid, now I'm not so much concerned with parallelism, because you can use angled multi-unit abutments and all of those things. I'm really concerned more about where is my screw access hole going to be and where is my AP spread. So those are more important on an FP3. So we'll talk about some of those as we go along. Now, you've got to make sure that you've got adequate restorative space for whatever type of prosthesis that you're going to be making. All right. So use the measuring tool that's located right here in the top of your screen. And you can simply go up here and measure from where the abutment is emerging out of that denture. And you can measure backwards from that down to the implant. And this one, before I even try to reposition it, notice it's right at the crest. And I've already got nearly 17 millimeters of space. So I know automatically that this is not a candidate for an FP1. Imagine how long this lower central incisor would have to be on a custom abutment to do an FP1. So that choice is out. This patient has lost a lot of bone over the years. FP2, that's kind of the middle ground, but here I would be looking at an FP3. I've got the 15 to 18 millimeters of space required. I can emerge lingual to that incisal edge. So this is going to be an FP3 case for me if I'm going to do it as a fixed restoration. Now, once you've got all of your implants positioned, your anterior implants are coming lingual to the incisal edge, and you might have to use an angled multi to do that, but you've got your screw locations located. You know that you've got enough AP spread. Once you've done all of those things, now it's time to choose which surgical kit you're using. And that's done in your implant list. So since I'm using Blue Sky implants here, I'm going to choose the Blue Sky Bio fully guided surgical kit. And when you do that, it's going to automatically set the parameters of the guide tubes to where they're in the right position. And it will automatically do that. Now, if you're using a different brand of implants, there's a lot of different kits that are listed in Blue Sky Plan, but not all of them. And by the way, that's not our fault. If you use a system and they're not in Blue Sky Plan, it's either because they haven't or they won't submit them to us. I mean, we'll put anyone's system in there. So go ahead and start bothering your reps and the higher ups at that company so that they'll put them in. And that way you won't have to do anything manually. If you're using a kit that's unlisted though, you're going to have to just figure out the parameters of the kit, what you need to set the offset at, what the height needs to be. All of those things are going to have to just be entered manually down here in the box for the guide tube. Okay, so we've got our implants planned where we want them. And I'll just review very quickly how to make a soft tissue supported guide, because it's super, super easy. I didn't do a lot of soft tissue supported guides, but there are times when it's a good option. The only thing you have to do for this is turn on your guide tubes, turn on your denture, and then if you go to the guide fabrication panel, you see this option that says create a scan appliance guide. And what that will do is it's going to take this denture, it's going to duplicate it, but it's going to duplicate it with the guided surgery holes built into it. So it's going to be an exact replica as far as the fit goes. And that's why this is important, that you want the best fit possible before you import this. Okay. So once we push create scan appliance guide, this is what the software will fabricate. And again, it's just a duplicate of the denture. it's going to clear out a space around each drill hole so that you can get your handpiece head in there. But the rest of it is going to be identical to your denture, okay? So you can see the underside fit. So when is a soft tissue supported guide a good option? It's a good option when the patient has a really good definitive seating position to their denture. Obviously, if you put the patient's denture in and it's been relined and it's got the best fit possible, and yet it's still wobbling all over the place, that's not a good candidate for a soft tissue supported guide, because how do you know you're getting it in the definitive position before you pin it into place and start doing drilling? It's a poor option when the denture has a poor fit. The big one to me is that it does require sacrificing keratinized gingiva, and most people who are edentulous do not have just tons of keratinized gingiva to spare. And so it just breaks my heart to go and drill a 5mm hole and lose 5mm of keratinized tissue. Now, there are ways to address that. One way, I'm getting some feedback here. Is everyone else hearing that?
Yeah, Corey, it actually shows that you're logged in twice.
Really?
Yeah.
Well, let me escape for a second and double check that.
I've muted that out. You should be good now.
Okay. All right. Well, I'll just go on. Still see the screen okay?
Yeah.
All right, great. So one thing that you might consider is kind of a middle ground. Maybe they got a great ridge, but they don't have adequate keratinized gingiva. One of the things that we would do sometimes is just use it for pilot holes, so that maybe you're only making a 2mm hole in their keratinized gingiva, and then lay the flap. But then you've already got these holes drilled that are marking your depth and trajectory of your osteotomy. And then you can just sew up around that. So you end up not having to sacrifice as much keratinized gingiva. The other option is you could just do the regular old guided surgery and maybe blow through the keratinized gingiva. If I do that, then I would suggest don't immediate load those, because you need that keratinized gingiva. I would suggest that you maybe put on some cover screws, leave your implants deep subcrestal, and then just sew the tissue up and let it all granulate over. And that way you can come back in 3 to 4 months and you can actually split the keratinized gingiva band and then leave those edges unapproximated, and the whole middle is going to fill in with keratinized gingiva. Danny Doming is kind of the master of this. That guy can grow keratinized gingiva out of his butt if he wanted to. It's incredible what he does, but he'll leave flaps, open 10mm sometimes, and maybe put PRF, but sometimes not even that. And it's amazing how good it granulates in with keratinized gingiva. So if you're not committed to doing a one-stage procedure and immediate loading, you've always got that option to come back and regain keratinized gingiva that way. Quick word on pins. Yes, you can add pins. They're great. If you want to add a pin, go up to the Add Implant tab, and you can either use the pins that Blue Sky sells, or you can choose a custom pin and enter those parameters manually. But what you want to do, especially if it's a soft tissue supported guide, is you've got to make sure that that pin is going to pass through the denture and into the bone, because otherwise, what are you pinning together? You're not going to be able to pin anything. So make sure you are careful with your positioning, that it's in between implants. It's not going to poke through the lingual. There's a lot of bad stuff with big names in the floor of the mouth that you do not want to hit with a drill. So when you're positioning this, make sure that the apex of that pin is not penetrating through the lingual cortex. Okay. And so here's the pins in place. I'm going to skip this. This is, well, I'll show just a second of it. This is a soft tissue supported guide where I'm pretty much doing pilot holes. And these were the old direct cut drills, which we still offer. That's a 2.2 or 2.6 drill. But notice how I'll use this. It's a flapless surgery. So I'm going in and I'm gonna kind of go up and down. And then once I touch bone, I'm just drilling right through the tissue. Once I touch bone and feel something hard, then I'm going to get all the way out of the osteotomy, get all that tissue out of the flutes, and then just proceed with an up and down motion, going a few millimeters at a time with lots and lots of irrigation. And that's an important point on all really guided cases, but especially full arches. Don't try to make your osteotomy in just one big shot, do it 1 to 2 millimeters at a time. Slow yourself down, because if there's any reason I see a lot of people start having more failures or crestal bone loss when they start doing guided, it's because they tend to make their osteotomy just fast and furious. They go in there and they just, in one big motion, in 5 seconds, they've got their whole osteotomy. Well, you shouldn't do that, because one, you're not getting any irrigation down there. Two, your flutes are filling up with bone, which means that you're pretty much burnishing bone and burning it and removing all the cell vitality, as opposed to if you were to go slow and easy, keeping things cool, you'll have a lot better results. Okay. So that's soft tissue guide. These were 10 implants that we placed on this patient using that method. And I just like this quick video that shows the accuracy of this. This was the first case I ever did with soft tissue supported guides. And a cool thing you can do is you can actually take a post-operative scan, pull that into the pre-operative scan where you did all your planning, and you can see how you did. So you can see these are the implants placed post-operatively, and now I'm going to turn on the planned implants. And look at how closely those coincide. So that's a really good accuracy. It got my implants exactly to the depth and the position that I wanted. And so as long as you've got a great fit to that denture, then you should be able to get very accurate results like this. All right. Now let's go over and now switch to the bone supported guides. I covered all that because it's still the same starting point, whether you're doing bone or soft tissue supported. And I did want to throw out a disclaimer. I'm not going to be teaching the stackable guide approach because there's a bunch of patent issues that surround that. There's numerous companies that are doing those commercially. They're very protective of their patents, and there's lots of litigation surrounding that. So the easy thing is just avoid doing them. There's no reason that you have to do a stackable approach. You certainly can. It's not at all difficult to do, but I'm not going to be the one to teach you because I don't like being sued. So knock yourself out if you want to teach yourself. Or just consider using one of those commercially available systems. Okay, there's InSequence and Chrome and iBore and 360 Image 360's anatomic guide. There's a bunch of options out there that exist. Consider using one of those. Obviously, you'll pay more, but they are good products. Okay, so I don't have any issues with those, but I'm not going to be teaching that. And I'll tell you too that in my experience, you know, we've done a lot of these cases now. I've done a bunch with Danny Doming and Knife Sonata and several other people. And in our experience, it's really no more difficult to use individual swappable guides than it is to use the stackable. If anything, I find some of the stackable options to be bigger in profile and more difficult to seat initially. Now, once you do initially seat them, the advantage is that they're there and you don't have to mess with them anymore. You can just stack everything on top. But if you don't mind doing swappable, again, from our standpoint, we've not seen them be any more difficult to use, but they do have the advantage of being far easier and cheaper to fabricate. And you're not going to need to do near as much fancy software work if you go with just swappable guides. So that's what I'm going to be showing here. Just as with a soft tissue supported guide, the starting point is a dual scan with ideal dentures and the patient biting in to occlusion at the desired VDO. That's your starting point on all of these. All right. So we're going to bring in the dentures the exact same way that we did in the soft tissue supported case I showed. And once you get to that point, you've got your cone beam scan of the patient open, and you've got both of the dentures or one of the dentures if you're just doing one arch, and you've got those imported. Everything's the same, whether you're doing soft or hard tissue guide. But once you've got those in, that's where it's going to begin deviating, because now we're not building a soft tissue supported guide. We're going to build it on the bone. So the next step, if you're going to do a bone supported guide, is you're going to have a STL model of the bone to build that guide on. And we do that through a process called bone segmentation. Now, I do have a YouTube video that goes through how I do bone segmentation. You could do it purely within Blue Sky Plan. It'll take a little longer. There's some hacks that I show in my YouTube video that use Mesh Mixer and Blue Sky, and that combination of the two has given me the fastest result. And so it usually takes me for an average jaw about 15 minutes to do the segmentation. But that's after I've done a zillion of them, right? So your first one will take you 3 days, and just realize that there's a learning curve to this. But if you don't want to mess with that, then you can simply outsource this to Lab Pronto, to image 3D conversion, and they'll do an excellent job. They'll segment your jaw and just give you back the STL, and it's pretty much a no effort option. So this is the step I see most people getting hung up on in the full arch bone supported guides. So if you're having a tough time with it, don't worry about it. Just delegate that out. It's 50, 60 bucks an arch for the segmentation. And again, yeah, that's money, but remember, these are huge cases that are very profitable. Remember what you're comparing to as well. The numerous commercial products that are out there that are going to range from a few thousand up to several thousand. Okay, so that's very inexpensive for what you're getting. Now, I'll go through real quickly how I do bone segmentation. A lot of people have messaged me, hey, did y'all get rid of segmentation? No, we didn't. It's just in a different module now. So it's going to be found in the model editing module. So go up to the top right, find the model editing module and switch to that. And then you're going to want to isolate whatever jaw that you're going to be segmenting. So if the jaws are not touching, you could hit isolate and then simply click on this mandible, for example, and it will isolate it like this. If they're connected together, like up here at the TMJs, then you could simply take your cut tool, cut right here, and then isolate, and it should isolate the jaw by itself. So we've got the jaw isolated, and again, I'm showing my little cheaters method that combines Mesh Mixer and Blue Sky. So the first thing I'm going to do is just go to the surfaces panel, and there's a button here that says create model. Now, all that button is going to do is it's going to turn this 3D rendering into an STL. Okay, it's a one button thing. It takes no effort, and it'll take about a minute for it to render it. But now we have an STL of the jaw. The problem with this STL of the jaw, though, is that, do you notice the porosity up here on the top? The reason that it does that is because, just like with the 3D rendering, all that the software is doing is it's saying, okay, everything above this density threshold, we'll call that bone, and it'll make it STL. But everything below that density threshold is not going to be bone. And so that's how you end up with the STL kind of looking like the actual bone, because it's going to have all these holes, porous areas, maybe areas of immature bone that don't render. And so we couldn't make a guide on this alone. And this is why, I mean, if you look in the cross section, areas like this is bone, but that method doesn't pick it up. Areas like this right up on top of the crest, if you build a guide directly on this, it's going to just drop straight down into this hole that's created. And that's not very useful to us. So we're going to go ahead and do a segmentation in Blue Sky plan as well. And where we're going with this is we're going to create an STL by segmentation and an STL via what I just showed you, and we're going to combine them. We're going to get the best of both of those. And when combined, typically you're going to have a really nice looking model. Okay, so let's go and do the segmentation. You'll go to Panels, Segmentation, and you're going to choose Advanced Jaw Segmentation. Up here, it's the bottom option on the upper right, and it's going to lead you through a wizard. So the very first step, it's going to ask you to indicate what area of the jaw you want to segment. Okay, so you're going to go to your pan window, you're going to just draw this box, and based on whatever area you've told it you want to segment, it's going to generate so many slices that it wants you to go through and actually tell it where is the bone in these. So it's essentially giving the software a head start and identifying certain areas as bone, and then it will extrapolate all that and try to create a closed 3D watertight model. All right. So once you've outlined the jaw, and I did a really big area right here, but there's no reason I need to segment the angle of the mandible or any of this stuff. In fact, if the implants are all going to be between the foramina, you can minimize the amount of work by just outlining maybe from here to right here, to just distal to those foramina. And that's going to make for fewer slices to do the segmentation in. All right, so based on that big box, right, in the bottom right here that I drew, the software says, okay, well, he wants to do all those areas of the bone, and it's going to generate so many slices. So the box that I drew it gave me 26 slices that it's going to want me to go through and identify the bone. So the way these tools work is you've got an intelligent lasso. If you were using the intelligent lasso, then essentially you would hold down shift and you would lasso all of the bone that you see in the slice, and it's going to do the same thing. You've got a density threshold here that you can play with to dial in the settings, but it's going to turn everything, in this case of a density of 550 or higher, and it's going to turn it pink. Okay, and the goal here is that in every slice, we want to identify every single piece of bone in that slice by turning it this pink color. All right, so since that tool in the intelligent lasso leaves some holes here, these didn't meet the density threshold, we can fill it in with some other ways. We could lasso with the normal lasso tool where it just includes everything you encircle. You could use the brush tool. But if it has a continuous pink boundary around it, then you could just hit fill holes and it's going to fill that in. All right, this is what you're going for. You're looking for a solid slice on each one of these that you go through. We'll go to the next slice. You do the same. I always go intelligent lasso, see what it gives me. And in this case, it got most of it and it didn't fill in the holes in this little area because you see there's a little area of discontinuity. And so I can fix that by just using the brush tool and just brush in a continuous boundary. And then I can click holes, fill holes, and it'll fill that in. So we're just going to go through all these slices. I'm not showing you all of them, obviously. It's going to do about half of them in the axial slice, and then it's going to make you do the other half of them in the cross-sectional slice. And an important tip I left out earlier, but do you notice that I've got this hint on from the other model that I made? So always turn on that hint because it's going to be very helpful for you to identify areas that were missed by that method and to help you close in areas. Like that bone is so porous and immature that it's hard to really tell if that's the bone, but with this model outline, it's pretty easy to tell that it comes straight down here. So I'll just brush in that area and then fill the holes, and now we'll have solid slices. So when you get through all of those and you get to the last slice, you'll click next, and it's going to perform the segmentation, right? And you can smooth it and inflate it. If you see that it missed a bunch and you want to, you could go back and hit previous and add as many more slices as you want. Generally, it's going to miss areas on the crest of the ridge the most because the crest is where you got old sockets and soft bone and all that. Your cortical plates, it typically picks those up very nicely because they're big, dense cortical plates. So you can add as many as you want, but with my little cheater method that I'm teaching you here, I just do the bare minimum number of slices that we can do. And once we get to this stage and it's segmented, you can hit create surface, and now it's going to make that segmentation an STL. Okay, so it'll call that bone model. And now you see that I've actually got two STLs of the bone. I've got the pink one that we generated originally by just hitting create model. And then the white one that you're seeing shine through there is actually the one done by segmentation. So here's the deal. If you do the bare minimum number of slices via the segmentation tool, it's going to miss areas. Okay, so unless you were to go back and add a lot more slices, it's not going to be adequate in and of itself. So as it stands right now, we have two STL models, neither of which alone are good enough to build a guide on. But if we could combine the best parts of both of these, it would end up a really nice model. Because like right here, you see on this top of the ridge in the posterior, the little peach colored model missed all that, but look, my segmentation picked it up. And then there's other areas like this spicules of bone that typically the density surfaces model picks up and your segmentation doesn't. So we're going to try to combine these. And the way that we'll do that is go to the file menu and hit export data. And whenever you are exporting data, anything that you have visible in this 3D window is going to be defaulted checked on to export. So I try to turn everything off there except for these two jaw models. If you didn't do that, you could just uncheck them at this stage, but I want to export both of these bone models. And when you export two models together simultaneously, it's going to turn them into a single STL, okay? And what I'll do is export that, save it somewhere on the computer, And now I go to Mesh Mixer and I open that file in Mesh Mixer. And that's what you see here. But the problem is, even though this is a single STL, it's still made of two independent, what we would call face groups. Okay, it's one STL composed of basically two groups. And that's not what we want. We want a single watertight model that has a solid exterior to it. And so we can fix that pretty easily by going up to the edit menu on the left-hand side in Mesh Mixer and hitting the button that says make solid. Now watch the loss of detail that happens as soon as I do that. So here we go, we're gonna do make solid, and boom, you get this, and yes, it's solid, but there's been a significant loss of the detail if you go from here to here. That's okay. We're gonna just change up here in the upper left where it says solid type. We're gonna change from fast over to accurate and tell it we're focused more on accuracy with the solid. You've got a solid accuracy slider here. We're gonna slide that all the way to the maximum. And then the mesh density of this, we want to be right about in the middle. And then once you've done that, you can hit update and it's going to reconfigure. So get this image in your mind of how little detail this has, and then we update it and you get this. Much more detailed, still has a continuous outer boundary. It's still watertight, and this is what we're after. So I'm gonna accept this. Now it will always create a couple of defects on the mesh when you do this, and those are, again, easy to fix. We go to analysis on the left-hand side. We're gonna click the button that says inspector, and we're going to auto repair all. So it's going to create a little indicator for every area where the model has a hole in the mesh, and you can just hit fix those and then done. And now we're ready to export this back out. So I'll export this model, and I usually label this final jaw segmentation. One thing to mention here is that when you're doing these big cases, you're going in and out of the software. You've got lots and lots of file types. So before you start the case, wherever you save your stuff, create a patient folder that you're going to dump everything for that patient's case into, because you're going to have reduced jaw files. You're going to have a reduction guide, a drilling guide, a prosthetic. You're going to have abutments that you have to go in and out with. So keep them organized and name them precisely so that you know what's what. I'll typically end up with about 20 different STLs in a case like this, which sounds like a lot, but you'll see it's not a huge deal as long as you've labeled them properly. So I'll put this into that patient's folder and label it final segmented mandible or maxilla. And now I need to bring that back into Blue Sky Plan. So remember, this is what we had, two independent STLs, neither of which would work on their own. Let's go to import STL and bring in that final jaw segmentation. Okay, so I find it, hit OK. And this is important. Anytime you import a STL, Blue Sky Plan assumes that you're going to need to stitch that STL. Well, in this case, our models were already oriented in the case. We exported them and we never messed with them while we were outside of the program. So when I import this, it's already in the right position. So I don't need to stitch it. In fact, if you try to do this, it will actually mess up the positioning. So just close this dialog box. And when you do that, you see that it imports the STL. No stitching is required. And look at the difference now between this segmentation and the one I showed previously, either of the ones I showed previously, both the bone model or the density surfaces model. This one has no porosity whatsoever in it. It actually, if you were to really zoom in, like on this upper right tangential, it's the tiniest bit beyond the bone. And that's actually a good thing. That's going to help your guides fit easier, and it's going to ensure that you don't have some little spicule of bone that keeps your guide from seating. So this is what we want. And now that we've got that segmentation done, we're ready to go ahead and make guides. So if I completely lost you like that and you're right now just completely confused, just outsource that, $50, $60 and you're done with it. And you can just pick up here and just import this job. So let me hit the questions because I see them adding up here pretty quickly. Where was the last one? All right, so is the same process if you have a wax model for 3 or 4 implants? I'm not sure if I follow what you mean by a wax model. If you could clarify that for me, I'll try to come back to it. Safe or recommended to place an implant right at the midline. Worried about that lingual foramen, as you should be. That lingual foramen can really cause you some problems, and I do try to avoid midline implants whenever I'm placing or planning these cases. And I can go back a few slides and try to show you this back when we were doing the pins, I believe. Yes, okay, this is a good example. You remember when I was telling you about your pins, watch where that apex goes. Obviously you don't want it to go into the floor of the mouth, but the other place you don't want to go is look up here in this upper right window, that tangential slice. You see the vessel that's coming in right here where my mouse is over? That is the area where the sublingual comes in. And if you violate that and you're way over here in the body of the mandible, they're gonna bleed like a stuck hog, but you'll be able to plug it with an implant. However, if you are to be drilling and you sever that thing relatively close here to the area where it enters the mandible, well, remember, arteries are muscular, and what the muscles do when they're severed, they contract. And so what's really dangerous is that vessel can contract back into the floor of the mouth, and it is a gusher. It'll start pumping out blood, and as it does, it's a closed space. There's nowhere for that to go anatomically. And that's when you start seeing the patient's floor of their mouth swelling, and that's a real medical emergency because it can absolutely occlude their airway. So again, if you're very experienced and capable of dealing with the complications of that, not knock yourself out, but I generally try to avoid it unless there's just no other option, just for the safety of the patient and because I don't like changing pants in the middle of a procedure whenever it starts bleeding like crazy. All right. I used Dentiste implants and called the rep so many times, but it looks like they're not willing to give it any alternative to try it manually. Michael could probably speak to this more, but it's kind of our policy that we don't want to reverse engineer other companies' kits and put them in, because then if we screw something up or we put in a wrong parameter, we're kind of on the hook for it. So we're happy to put anyone's stuff in, but the manufacturer needs to submit it. So just keep nagging them and get every other user of them that you know to start nagging them. Michael, anything you'd add to that?
No, that's pretty much it. We're happy to put into any system, but we can't go and try to figure out the numbers ourselves. We need the cooperation and approval from the manufacturer. So if they send it to us, we're happy to put the information into the software.
Yeah. Okay. I missed this one. Oh, go ahead.
You're able to X out the question. If you move your mouse to the top right, you'll have a dismiss.
Gotcha. All right. Someone else asked, what is the best method for mapping the nerve? You do have the auto mapping tool. It works a lot of the time, but it won't always work. I don't have a live case pulled up right now, but remind me when I get towards the end of the procedure. I'll try to pull one up and just show you very quickly. I've also got YouTube videos on it. So yeah, I'll try to come back to that because there's a really precise way to do it that works almost 100% of the time. And that's usually what I do, honestly. I used, okay, we answered that. Do you have any example cases for practicing? I sure do. Be happy to give you those. If you will send me an email to cglenn@blueskybio.com, I will send you those. And I can also send this, this little cheat sheet so that you can refer back to it. If creating a soft tissue guide, is there a difference of fit in an optically scanned denture versus a CT scanned? Not one that you'll be able to appreciate. So again, if we go back to the example and say that, the cone beam has a voxel size of 100 microns, well, is 100 microns of potential, not necessarily, but potential inaccuracy on the underside tissue fit of a denture going to affect how it fits? Nah, not really. Not where you'll be able to appreciate it. So I wouldn't worry too much about that. What's more important though is just that the denture be fitting well beforehand, because if it's a sloppy fitting denture, you may have areas under there where there's huge gaps, and that's what you don't want. So make sure it's a well-fitting denture. How do you secure the guide? You can So I've done this where if they've got a great ridge form, I'll just sit there and hold the guide down on the ridge. And if it's very definitive and doesn't want to move around, I always put some pins into the case, but there's a lot of times that I didn't use them. So if that thing goes in there and I can hold it with one finger, usually I'll use my middle finger on the pallet, just right in the pallet to stabilize it. And then I'll drill with my right hand. On the mandible, I usually take these two fingers with my left, stabilize it, and then drill with the other hand. But yes, you could use the pins if you don't want to bother with that. And those are available in Blue Sky Plan. You can make them whatever size that you want. So that's totally up to you. But I would default to including pins. And then if you don't need them, don't worry. How did you get to compare the placement of implants pre and post-op? Okay, so here again, I don't have a pre and a post-op case to do this. It's kind of a hack of the software. Basically, we're gonna lie to the software and tell it that it's a scan appliance. The post-operative scan, we're gonna call it a scan appliance, and it's going to turn that into STL and import it. But I just don't have the stuff pulled up to show you. So there is a YouTube video that is on my channel that goes through the exact process. If you look on my channel, you can find it, or if you just want to email me, I'll send that to you. Same question on the next one. What about the magnet stackable ones? Yeah, they're great. Again, I'm just staying away from anything stackable due to the potential of patent infringement or lawsuits and all of that kind of stuff. So I'm not going to tell you what to do, but use it at your own risk, because there's definitely people watching closely for people to post those kind of things online. And if it's in a country where those patents apply, you can be assured you're going to be getting a call. Does Lab Pronto plan out a whole case with bone segmentation? I believe the answer is yes, Michael.
Yep, we have a whole array of advanced surgical guides. You could get everything done, all of your digital work through Lab Pronto, surgical guides. And
extremely affordably, I might add. I mean, you could probably get it for, I think, $600 or so. So it's really great. Great. Where can I access it? I'm not sure what it is, but if you'll clarify, I'll tell you where. Should we use the inflate button? I usually will hit inflate once and smooth once and then create surface. That's just me. If it looks accurate without doing that, don't worry. Hi, Doc. Like the stainless steel high vac suction tube, what brand is that? I don't know exactly what's being referred to there. So I don't know. If you'll clarify for me, I'll try to answer that later. Hi, Cory, would you suggest that getting a company such as Image 3D Conversion? Yeah, they're great, especially if it's frustrating to you, or if you don't have the time to do it and you could be more productive in an operatory, then outsource it. I mean, surely you can generate more than $50 going doing dentistry than it would cost you to just outsource that. And they do an excellent job, by the way. Steven says, hi, Cory, do you think in Mesh Mixer it is always better to auto repair all or go into each individual marker that shows up? For this, I always hit auto repair all. There are other circumstances where, yes, I might do it individually. An example would be, let's say I've got a model and I've put a base on it and I've extended that base, but I don't want it to be closed. I want to be able to see the inside of it. If you were to hit auto repair all, it's going to close in the entire top plus any other errors in the mesh. So the way you would avoid that is if you wanted to maybe just do individual errors in the mesh, you can click those little dots or bubbles that pop up and it will just fix those individually. So it's kind of case dependent on whether or not I'll do that. Is it the same if we don't have a denture, but we take an impression with markers? Well, the answer is that you could do a guided surgery, but you don't know where the teeth belong. So that's really the entire purpose of doing this, is so that we know where the teeth are, right? We're trying to plan with the end in mind. So once we know where the teeth are, and that's happening by the denture as opposed to an impression, once we know that, now it's easy to plan the implants in the perfect position. If you don't have that information, then more than likely you'll end up with some facial screw access holes. You'll have to use more angled multi-units, which I hate. I really try to avoid using angled multis as much as possible. And so I consider it a necessity to always take the denture scan as well. How much accuracy do we need in the final segmentation? You definitely need it to be accurate, because if it's not accurate, your guide's not going to fit. Now, just a quick word on that. You can have what I'll call positive and negative errors. A positive error, if I can find an example. A positive error, if we were to look at this, would be, let's say that this little area right up here at the top where it's kind of going down, let's say we went a little overboard with segmentation and this was just flat over. And so in essence, it's called something bone that really isn't bone there. Well, that's not a huge problem unless it's like that all over the place, because it's just going to create a tiny spot underneath the guide where there's a gap between the guide and the bone, but it won't inhibit the fit of the guide at all. On the other hand, if you were to include negative errors, so let's say that this corner right here, that is bone, but your segmentation missed it, and then you build a guide on that, well, now your guide's not going to fit because it was built on a model that was missing part of the bone. So you get to the mouth and this whole chunk of bone holds it up from seating. So if you're going to err towards having more than you think needs to be segmented rather than less. And if you're going through those slices and you're looking and you're like, man, I don't know if that's bone or not, err towards including it as opposed to not including it. Okay. If you do a manual wax of an all arch and plan to place 3 to 4 implants. Okay, I think so. So the question is, maybe you just want to have a wax setup done on a record base, but not carry it all the way through to processing, maybe for cost savings. Technically, yes, you can do that. It's not going to render real well in the software though, because wax shows up almost just like air does. So if I were going to go that route, what I would do instead of just using that actual wax denture is I would either use a conventional denture duplicator and make an acrylic copy of it that I could put the markers on, or I would optically scan it inside and out and make a 3D model of it, and I would 3D print that version. Because once it's in acrylic or resin, it's going to render a lot cleaner in the software, and you're not going to be, guessing at where the contours are. Okay. Good question though. With pins, would you suggest in some cases to go through both cortical plates? Yes, on the maxilla, no on the mandible. But even then, usually I don't even do it on the maxilla. Could you also go through suturing of these to have a nice site to suture through the tissue and through the pin osteotomy? So the pin osteotomy, if you're using the Blue Sky pins, it's going to be a 2.2 millimeter pin, and it's going to set the guide tubes for that. It'll tell you what guide tube to use, and it will tell you what drill you need to use, which is the drill T22S. And that's going to make a 2-2 hole for your 2-2 pin. So that would be an additional drill you need to buy. But if you're using other brands of stuff, then you kind of got to figure all that out manually. Like if you're using Nobel pins, for example. The suturing, let me come back to that towards the end, because we've got a clinical case I can show you, and that will hopefully help you. How do you map out nerves on a really porous mandible? Okay, so I got to do that at the end as well, because I'll have to have a case pulled up. Can you send examples? Yes, if you will email me at cglenn@blueskybio.com. What do you use to reline dentures? I used to think you had to use the same type of acrylic as the denture is made of. In actuality, I got some cases sent to me where they used PVS to reline the denture, and those rendered okay. So I think it's fine to just use some medium body PVS to reline it, and then you can scan the patient wearing that. Tell you what, Kareem, if you could email me, because I probably will not be able to get these email addresses out of this after the fact. Is the hammerless guided sinus kit available in Europe? Yes, it should be from our European distributors. So I know in the UK, Implant should have it, and I believe there's some French distributor and maybe a couple of others, but you hopefully should be able to find that. If not, email me and I'll try to find out. Shane, yeah, if you could actually email me at cglenn, that would be helpful. Please mention the email again, cglenn@blueskybio.com. Please send the cookbook. Yep, I'll do that. Thoughts on radiographic PVS, Parkel? You can do that, but frankly, all PVS is radiopaque because it's got platinum in it. That's part of what makes it set up and initiates the condensation reaction. So most PVSs show up great, and you shouldn't have to use any particular brand. With bone supported guides, would you suggest having a soft tissue STL to overlay the segmented bone? You can if you just wanted to make a soft tissue model, but if we're making bone supported guides, then the soft tissue model doesn't really help us that much. And furthermore, if you've done a scan of their denture and it was a really nice fit, there is the option in Blue Sky Plan to just digitally pour a model of the inside of the denture, and that can be your tissue model, and it'll already be stitched in position. So that would be my method if I was going to do that. I have several cases of the bone guide where it needs some degree of altering to allow the guide to seat. That probably goes back to what I was saying about having those negative errors. Or the other really common one I see is movement in a scan. That's a big, big deal, especially on a full arch case. So always, before you release your patient, look at the scan, and if you see areas where the image looks stretched, if you see areas of double imaging, any of those things, retake it, because you're not going to be able to do those guided, because the DICOM rendering is not going to be true to the reality of their anatomy. It's going to be a mandible, and let's say they get bumped in the back by the scan head, it's going to cause them to move, and that section in which they were moved is not going to be the correct anatomy. So when you make your segmentation of the bone, it doesn't correspond to what they really have, and that's going to require adjustments. So make sure it's a really accurate CT scan. What if you don't use Mesh Mixer and use ChichiBox? I couldn't speak to it because I've not used a lot of ChichiBox. If you can do that, great. I would love to know it. Will you provide a copy? Yes, it'll be available on YouTube later with bone reduction guides. Would you suggest adding an offset in Mesh Mixer? I usually don't, because again, if you look at my segmentation, it already has a little bit of offset or positive error. So I don't generally do that unless I had a particular area I'm worried about it seating. So I wouldn't do that usually. I tried to buy and couldn't get just as it was released. Okay, yeah, I couldn't tell, but I could look into it on the hammerless kit in the UK. All right, so ChichiBox won't do it. All right, so someone else can chime in, and they said that that will not work. So sorry about it. All right, so now we've got segmentation. We're back to this, and now we're ready to make all of these guides. So this is a different case from the one we did previously. And so just as a learning exercise, I went ahead and I put in an implant just right up here near the top of the jaw. So let's see, if I got the implant in that position, could we do an FP1? First of all, do we have adequate bone volume? I'm not loving what I see there, because this top 2 to 3 millimeters, maybe more, of this implant has virtually no bone around it. And I can just tell you from experience, that is going to resorb over time. You want to try at all costs to maintain 1.5 to 2 millimeters of native bone on all sides of that implant. So if I was looking at this jaw, I would be putting this implant much deeper, which would obviously mean bone reduction. What about restorative space? Well, we've got 13.5 millimeters of restorative space. That's on the high end for an FP1 prosthetic. But technically, if we could put it in this position, yes, you could do that. Is there too much restorative space? A little bit, not terribly so. My biggest concern here is just that I don't like the positioning of the implant in the bone. So despite having adequate space, I'm going to place this implant deeper to get more bone on the buccal and lingual. And by the time I do that, I'm down here before I get a couple millimeters of bone on either side. And now when I measure this, I've got 18 millimeters of restorative space. So what kind of prosthesis are we looking at? Almost by default, well, we're going to probably be doing a FP3 or a hybrid type restorations. So we've got the 18 millimeters of required space here. And when we place the implants, when we're positioning implants for an FP3 case, really I would say for most full arch cases, I try as much as possible to keep the platforms of the implants at roughly the same level, Because just like you don't want a roller coaster occlusal plane, you don't want a bone level that's going up and down where one implant's super deep, the other's real shallow. It's going to make your life a lot easier if you can try to get them within a millimeter or two of being at the same level. And this is a question people always ask is, should I distoangulate it? Or they'll look at a case and say, well, you're an idiot, you didn't distoangulate it, and that's the all-on-4 protocol. Well, ask yourself the question, if you were to distoangulate in this particular case, would it increase the AP spread? Well, what I do generally is I try it both ways. I've got this big long abutment, and so I'll position it straight up and down, because if I can position them straight up and down, that makes everything in the surgery much easier. It makes the prosthetic pickup easier. Seating the multis is far easier. So I'll try it both ways. And if I can get at least back to the second premolar with implants straight up and down, there's no way I'm going to distoangulate. There's no point. It doesn't gain you anything. The reason that we distoangulate and that the all-on-4 technique was introduced was for these severely resorbed patients that have no bone distal to the foramen. And the only way to get adequate AP spread is to distoangulate and kind of lean the platform of the implant over the top of the foramen. And by doing that, you can gain a little space. But I find, I would say probably 50% of the time, that if I try it both ways, distoangulating doesn't buy me much. And so if it's not going to gain me anything, I'm sure not going to complicate my life by adding distoangulated implants and having to use angled multis. Okay. One thing you've got to consider on that, and again, this is out of Mish's book, is that you can cantilever up to 1.5 times the AP spread between the distal-most implant and the anterior-most implant. So a lot of things factor into that. The arch form, you know, if you've got this square-shaped arch form, half your or most of your implants may end up in a straight line, which means you're not going to be able to cantilever near as far. In a big V-shaped arch, typically you can get a really long cantilever because they tend to have a lot of space between this frontmost and the distal-most. So, you know, you can kind of measure that out. And if we look at this particular case, right now I've got the implants in a straight up and down position. They're 2 millimeters inside of the foramen, so they're a safe distance away. And you can see the red here indicates the distance from my anterior-most implant, and then a line drawn between the two distal-most implants. So I've got this much of AP spread as it is, and then I can cantilever 1.5 times that. So when I do that and it puts me back here, and I know I can safely cantilever to a second molar, why on earth would I use any angled implants and complicate my life? There's no benefit to it. If, on the other hand, I could only cantilever maybe half of a first molar, well, maybe there's a reason to do it then. And I'll tell you, on cases that I've done, I usually, on one arch or the other, and it's usually the mandible because the aesthetics won't matter there, I try not to even include second molars. That way I minimize the cantilever. I make the case less risky in the long term due to a longer cantilever. And aesthetically, it doesn't show. And if a patient has first molar occlusion forward, they can chew anything in the world. They're going to have no problems functionally. So that's my take on it. I'm sure that some diehard all-on-4s will disagree, and that's fine. You're right. You have the right to be wrong. So you can change your mind to my way of thinking anytime. All right. So yes, this is just reiterating what I just said about all that. Always try to start with the implant straight up and down, and then only distoangulate if it makes sense and if it gains you some AP spread. Okay. And one of the big reasons that that does make your life easier is that straight multi-unit abutments are just stupid easy to place. You just screw them in and you're done. You don't worry about timing or any of that stuff. But the moment you switch to an angled multi-unit abutment, first of all, they're hard to handle. Second of all, they're going to be difficult to get at the screw access hole. They're oftentimes difficult to seat and need bone profiling. And then you're going to have to, if you're doing this guided, you're going to have to be very precise with the timing or the degree of rotation of your implant, because otherwise your emergence position with that angled multi is not going to be at the exact position of where you had it in your planning. So you have to make timing marks and all kinds of stuff. So distoangulated, it's fine. I'm not dogging it. All-on-4 is a great treatment, but don't use a single cookie cutter recipe for every case, because not every patient is the same. All right, so here were my final implant positions. There's a very minor distoangulation on this, but no more than what I'm doing here, maybe 5 to 10 degrees. There's no reason to use a distoangulated abutment. So these will all be straight multis. Again, I placed them down deep enough, and the way that I've determined how deep to go is, one, how deep do I have to go to get enough bone around them? And so I'm going to put them that deep. And then secondly, how deep do I need to go to have adequate restorative space for what I'm making? So maybe you've got adequate thickness right at the crest, but if it only gives you 10 millimeters of restorative space for a hybrid, that's not going to work. So you're going to have to put them deeper, which is going to mean bone reduction. All right, so this case obviously is going to need probably 6-7 millimeters of bone reduction. These implants, I think, are 11. No, these are 13. So yeah, that's probably half that distance. So about 7 millimeters of bone reduction. And now we're ready to go ahead and make the bone reduction guide. All right, so the bone reduction guide, probably all of you, if you've ever made a guide in Blue Sky Plan, have experienced where you forgot to turn on the guide tube and you draw your guide. Well, if you do that, then it just makes pretty much a night guard because you didn't have a tube turned on. Well, I want to do that intentionally here. I don't want any of the implant guide tubes turned on right now. The only tubes I want on are these pin tubes, because this is what we're going to turn into the bone reduction guide. And we most definitely do want that bone reduction guide to have pin holes so that we can pin it into place. So I'm going to turn those on. And then I'm going to go to the guide fabrication panel. And what are we building the guide on? We're going to build it on the solid mandible in this case, or the maxilla if you were doing an upper. Hit draw curve, you're going to draw your contours, and you do need to be careful about how deep you go with your contours. There are some anatomic limits of how deep you can go. So obviously you can't seat a guide past the mental foramen and pinch it. You're going to cause your patient to have paresthesia. If you were to look at like the lingual, you've got that genial tubercles down here. That's where the sublingual is coming in. It's where you've got numerous muscles attaching, like the genioglossus, the other genio hyoid muscle. You know, there's several that attach right there. You do not want to reflect that. Hilt Tatum, in a lecture I was in one time, said that early on he was doing a full arch case, really resorbed patient, and he reflected that, not realizing it. And he said, for a moment, I was in pure dental bliss because the tongue rolled back, and it was just like working on a typodont all of a sudden, because he had severed that attachment, and now the tongue just contracts and rolls back. And he said that was interrupted a short time later by realizing that I'd done this and that the patient's tongue was about to occlude their airway. So don't go all the way down to the genial tubercles. The other place you need to watch is this mylohyoid ridge. Unless you're going to split the mylohyoid muscle, then you do not want to go beyond this ridge right here. Okay, so just watch those two anatomic things, plus on the buccal, your mental foramen. Those are the main ones you got to watch out for. So once we've got our contours drawn, we can go ahead and create the surgical guide. And this is what you're going to get. So it's a guide that doesn't have any guide tubes on the top, which is fine because we're using this as a bone reduction guide, but we do have the pin tubes. That's what we want. Now here's again where you're going to have to get organized and start labeling these things. So as soon as I make this, I'm going to label it pre-reduction guide. All right, and you'll see why I labeled that here in a minute. Okay, so once I have that, I'm going to go ahead and duplicate both the mandible and the pre-reduction guide, because we're about to start cutting on both of those. And if at some point you screw it up, you don't want to have to go backwards and redo all this stuff. So if you screw it up, you can just delete that. You can then go back and just start making your cuts again. So I'm going to duplicate these, and I'm going to relabel one of those jaws, the one that I'm going to cut on, as the reduced mandible or maxilla. And then the extra guide, you know, the duplicate of your pre-reduction guide, that's the one I'm going to call the reduction guide. So I'm going to leave my duplicates turned off, or the originals turned off, and now we'll turn these into the reduction guide. So The first thing you're going to need to do is on both your jaw, and on this pre-reduction guide is you're going to need to go down in the surfaces panel, select it, and then turn the transparency about halfway up. You're going to need to be able to see through these models in order to know where to make your cuts. Same goes for the mandible. So we turned the transparency on 50%. And now we're ready to make the cuts. And so now I do turn on the implant tubes because I need to know where to make my cut. And usually I make that cut about right in between the bottom of the guide tube and the top of the implant. Okay, that still leaves my implants a bit subcrustal, but it's going to give room that the tube is not going to be impinging on any bone anywhere. So I would recommend that you look at this from the lingual. Okay, if you've used the cut tool, you know that it cuts indiscriminately anything that is in that lasso, whether it's what you're intending to cut or something that's behind it. So by looking at it from the lingual, we don't have anything out here behind it to mess up and cut. And I zoom in quite a bit, and I'm going to use this cut all tool. Now the cut all tool is going to cut on whatever surfaces you have visible in this 3D window. So what I'll do is choose cut all, and I'm going to come in here and I'm going to just initially, I usually do 1 or 2 implants. So let's do these middle 2 implants. I'll hit cut all, and then I'm going to lasso around it, and I'm going to go right in between the head of the implant and the bottom of the guide tube. And I'll just do a small area like that. Okay, so you can see where I made that first cut. The reason I'm not doing it all in a single cut is because I can't really see, you know, I'm looking at an arced shape, and it's hard to be able to see if I'm keeping things in the same plane. So I usually do the front 2 implants first, and then I'll rotate it a bit. And now I'm going to look from this side, and I try to line this up where when I look, I'm going flat through this cut that I'd made previously. That way I keep all the cuts in the same plane. And once I've got it oriented that way, now I'll make the cut on this one. So I would go in with the cut all tool and pretty much outline it as I have in red right here. And that's going to make that cut. And then finally, we'll rotate it to the other side. We'll line up and make sure we're in the same plane, and then make the final cut. And once you've done that, now you have your bone reduction guide. All right, it's really quick to make that. That shouldn't take you more than about 5 minutes or so to make. So we got our bone reduction guide, which is pin retained. So that's step 1. Let me hit any questions that have added up here. Could you make an example of an osteotomy surgical guide? Yes, that's what's coming up next. Surely this is a bone reduction, more upright implant and an FP2. I mean, it's 18 millimeters of space in this particular case, and we're removing 7 millimeters of bone. So to me, that adds up to a hybrid pretty much all the time. So yeah, it looks like you corrected there and are putting these as an FP3. But, you know, parallelism is, to a degree, it's important with straight multi-unit abutments. But again, if you're 5 to 10 degrees within parallel, I'm not worried at all about using some straight multi-unit abutments on that. So there is very, very little disto angulation on these implants back here. So I'm just not terribly worried about that. When you're picking up the MUAs, would you suggest picking up 1 or 2 at a time, or all of them at the same time? Your first few cases, do 1 or 2 at a time, because that is where things can go really wrong. Once you've done a few, like most of the cases I watch Danny do nowadays, he's picking them all up at one time, but he's also done this 100 times or more. So just kind of go at whatever pace you like. There's not really a rule on that. Do you think these guides are better designed in Mesh Mixer? No, I don't think Mesh Mixer can design a guide this good, nor can it show me all my implant positions or do the transparency that I need. So there's some ways that I'll make the osteotomy guide with Mesh Mixer, but no, for the base guide, I would not use Mesh Mixer for that. Could you use a seating window to do this as well? Technically you can, but it's a lot more difficult to control the cut. And, you know, sometimes they're not in a perfect plane. Sometimes they need a little arc. Like if you look at the one back here, I've kind of got this gradual shape, rather than if you used a window tool, it's going to be an abrupt 90-degree angle there. And you're going to have to go back and shape that up after you unseat your guide. Could this be done more time consuming, but more accurate in mesh mixer? I still don't think so. Is the stackable? No, I'm staying away from stackable because of patent issues. Do you always use pins on a bone supported guide? Generally, yes, because these things, you got to flap them down to their liver to get them seated. And once they're seated, the last thing you want is for that tissue to kind of close up and pop your guide up. So when you finally get them in place, you want to pin those things into place. And the other advantage of that is that all of our guides, the bone reduction, the drilling guide, and the prosthesis, they're all going to share those same pinholes. And so that becomes a way of checking yourself to make sure that everything is seating fully and that you're in the same position from one guide to another. How can you parallelize all 4 implants? You do have an option. If you right-click an implant, you can say align with another implant and then go and click the implant that you want to parallel with. On a hybrid, I'm really not all that concerned with parallelism though. If I was doing an overdenture, yes, but I'm not too worried about it here. How can you parallelize? Oh wait, I mean, is there any way to correct the manual positioning in the software? Yeah, you can align like I was just describing. Is there a common MUA height planned for? Yes, usually if I'm doing immediate load, I'm going to use a 3mm multi. And the reason I do that is because I tend to leave my implant subcrestal so that if there's a tiny bit of crestal bone loss, it's not a big deal. And so I usually use a 3mm multi. And the other reason is that way it's going to stick up a little higher and give you more room under the prosthesis for your tissue so that you don't end up with a big inflamed area where there's just not enough tissue volume. Which height to use? Usually 3s. If you came back at the time to restore and maybe the tissue has retreated back a little bit and that's too long, then yes, switch it out at that point with a shorter one. I can't really remember a time where I needed one longer than 3mm. If you're having to do that, then chances are you left your implant too far subcrestal, or you just didn't plan the implant in the right place to start with. How do I trust that Lab Pronto will plan it like you and can stay safe of a vital structure? I would tell you this on Lab Pronto or any service out there that provides you a guide. At the end of the day, they are not the ones responsible for the outcome. And so it's the surgeon's responsibility to verify the accuracy of everything before proceeding with surgery. So in the case of Lab Pronto, they're going to send you a case approval and you're going to be able to look through it and see where they've got everything. And if they're too close to a vital structure, you can say, no, I want this moved. But they're not going to proceed with the final until you give it your rubber stamp of approval. If you just say you approve it and then you get the guides and you use them in surgery and you never reviewed anything, and then you go and bag the nerve, that's on you, not the lab. So do check this stuff. I mean, you may not be the one making the guides, but you can absolutely look through it and see all the implant positions and their proximity to vital structures, as well as the depth and the restorative space and all of these factors.
And if I could just add in a statement regarding that, these types of cases come included with screen share consultation with the lab that did the planning. So they'll be able to discuss it with you, take you through it step by step, explain why they did and what they did and how they did it. And another point just regarding the labs on Lab Pronto are all labs that have been doing the relevant types of cases for which they're providing the services for quite a while, have the proper training, track record, and history to be able to handle, these types of cases.
All right. So yeah, I would tell you that whether it's Lab Pronto or anything out there, even a single tooth guide, it's the doctor's responsibility at the end of the day. They're not going to get sued. It'll be you. So make sure that, I think this is why it's valuable for a doctor, even if they are going to outsource the vast majority of their planning, to still know how to do it and to manipulate whatever software the lab is planning in, because otherwise you're just taking their word for it. And I mean, lab technicians are extremely knowledgeable, but they've not undergone the surgical training, right? So they can do amazing prosthetic work and stuff, but you've got to be the one that ultimately decides if this is a go or not. So do make sure of that. That's super important. Stephen says, but the seating of the guide will be dependent on making sure the right amount of bone is removed when you get to the next level. Actually, no. So the method I'm going to teach you, part of the reason why I do like it is because it's going to be an open face design. So if you left a little spicule a bit high here and didn't reduce it, it's not going to affect the fit of the next guide. He also asked, what's your opinion of Chrome? It's good. It's a good product. It's expensive. I don't have anything bad to say about it other than I couldn't make it work in where I practiced because I was charging $15,000 for the full arch restoration, implants, temps, the whole 9 yards. I charged $15,000 for it. So to spend $5,000 or $7,000 on a set of guides and prosthesis, regardless of how great they may be, it just financially I couldn't make it work. And so, yeah, knock yourself out. If you can charge enough to make that work, then I got no problem with it whatsoever. It's a good product. Quite nice, but extremely expensive. There you go. Is 3 pins enough to secure the guide? In my experience, yes, but you can add as many as you want. So that's totally up to you. You can add 10 of them if you want. Can we have confidence that Lab Pronto will do the jaw segmentation? I think is what that means as part of the surgical guide. Yeah, if you're doing a bone supported guide, they're going to have to do segmentation. And yes, the accuracy of that segmentation is critical. So just again, just like you're verifying your implants, you ought to also go through the case and just scroll through and make sure that that segmented jaw outline corresponds to what you see in all the 2D windows. Because if you see a giant chunk of bone that's missed and they've made the guides on that, that's going to be a prematurity. It's not going to work. So yes, the segmentation is very easy for you to verify the accuracy of, and yes, it should be done by default, but you still need to double check everything. And wish I could have been at the course with you and Danny in March. Yeah, I know. Unfortunately, we had this pandemic thing. So yeah, we're actually talking this afternoon about when we can try to reschedule that. Just a comment here. Thanks. We were doing 1,500 plus until COVID guides a month. And it is important for doctors to understand this. What we do digitally can't always be done clinically. Communication is the key with any case. And I assume this is a lab that's making these. So, you know, sometimes if all you're looking at is this digital data, remember, there's no cheeks on this, there's no lips on this. And so you might sometimes put a pin, like let's say way back here, and then the doctor gets it and says, hey, there's no way I can actually place that pin. Well, remember, they're not working in a mouth, they're working on these models. So it is a team approach, and you have to collaborate on a case of this size. I'll just be blunt, you're a complete idiot if you just outsource a case like this and you pay a big chunk of money for all these guides and then just go in and use it blindly and hope for the best. That is completely stupid, if I can just be real blunt. So yeah, communication is key. Rudy with Implant Concierge. Hey, Rudy. Implant Concierge is another one that I forgot. I think they do these types of cases too, if you're looking for a commercial option. Thank you for that. Okay, so would you agree that having a facial scanner or an intraoral scan, CBCT, is the best path? I know everybody's kind of on the wagon of the facial scanners right now, and I have one. But if I'm real honest, I don't find any more value out of those than I do from 2D pictures and just intraoral scans. Frankly, I like 2D pictures better for the smile design aspect, because the 3D scans, once you cut the mouth out and you're positioning these teeth that don't have the natural shading, it looks so unnatural to me that it's just hard for me to correlate everything. I know how to do it, I can do it, and you know, yes, you can absolutely make that part of your workflow. I just fail to see the value in the fabrication side of it. It looks cool, it's fancy, but it's got limited utility to me. Woohoo, I agree, hate all the lies. I'm not sure what that's referring to, but apparently we agree. All right, so going forward, so we've got the bone reduction guide, right? And I would suggest you go ahead and export this, save it, always save your cases. As you're working on these, this case may take you an hour, hour and a half, 2 hours. the last thing you want is to get to the end of it and then crash or your computer die and you lose it all. So every time you complete a step, save your case. And then I also go ahead and export the files as I generate them. So I would at this point export this bone reduction guide. And so hopefully you know how to do exports. Now let's turn back on the guide tubes, okay? So now we've got your implant guide tubes, and you can see that because of where we made these cuts, they're floating up in the air. Now at this point, you've got a couple of options of how you make the secondary guide. So I'm going to show you one option first, and we can talk about the disadvantages. But the advantage is that it's very easy and it doesn't require any mesh mixer. So you've got this file now of your reduced jaw, which by the way, you should have exported as well and saved it labeled reduced jaw. But your other option to make your secondary guide is that you could now just turn on the tubes, and just like you were making a plain old guide, you could draw your boundary and then push create surgical guide, and that's going to give you this. Okay, couldn't be easier. Very simple to make that. Now the disadvantage to this guide, there's a few of them. One is visibility. I can't hardly see anything of what's going on underneath here. The other one is what I think Stephen was referring to earlier, which is that if you come in here and let's say that you don't do this bone reduction perfect, right? Let's say you leave a spicule of bone sticking up here. Well, this secondary guide was made on the completely reduced jaw. So it assumes that you did that complete amount of reduction. And if you didn't, then this secondary guide is not going to seat fully. And it's going to be hard to tell that it's not seated fully because you don't have a lot of visibility. All right. So if you're going to go this route because you hate mesh mixer or whatever for time savings, you absolutely have to make sure that you fully seat your reduction guide and that you do that bone reduction fully. And if you have to err towards going just a hair too far on your bone reduction. We have some wiggle room just because we have placed those implants subcrestal, and then hopefully that will not be an issue. And we did several cases this way with no problems, but you do have to be careful to complete the full segmentation. All right, now alternatively, I'll show you the other design, and I like this one better. But the downside to this one is that it is going to require some mesh mixer. It's going to use a add tube function that we've not yet made available in Blue Sky Plan. There is another hack you could do to get past this in Blue Sky Plan, which I'll show a little bit later. But what I'm going to do with this method is make this open face drilling guide. And what that consists of is nothing more than your original bone reduction guide, which you've already got. And then we're going to turn on the tubes and we're going to export the reduction guide and the tubes, and then go into Mesh Mixer and just connect those tubes down to the guide. And that's going to make the same end type result. It's going to seat exactly like your reduction guide did because it is your reduction guide, as you can see. There's air or space under here of 2 or 3 millimeters. So if you were not perfectly precise in one area with your bone reduction, it's not going to affect the fit of this one. And it shares the same pinholes. So you'll know it's in place once you pin the pins into the same spot. If you can't get them to line up, the guide's not seated. All right. So with this guide, I can look back here and be sure that it's fully seated on the bone. I can, make sure that the pins all go in, and I've got a lot more room to have visibility to see what's going on and to get irrigation in there. And so that's a lot of reasons of why I prefer this design over the other, but it is going to take more time and it does require using Mesh Mixer. So let's show how I would do that. I've already exported my reduced jaw. I've already exported the reduction guide. Now I'm going to go in and export all of those guide tubes. All right. And then I'm going to open all 3 of those files in Mesh Mixer. So here's your reduced jaw, here's your reduction guide, and here's your guide tubes. But the problem is they're just floating up in the air. As is, this is not useful. So what we're going to do is we're going to connect those tubes down to the reduction guide, and now it's going to fit the exact same way. And you didn't have to go through the process of making an additional guide. You're just kind of modifying the first one. So the first step is that you need to combine the guide tubes and the reduction guide. You can do that by going in your objects browser, hit Control, and then select both of those files. Once you do, this box will pop up and you just say combine. And now that this is a single STL, we can go to the Edit menu, and there's a function called Add Tube. All right, now this is kind of a squirrely tool to use. It takes some getting used to, but once you kind of have the knack of it, it's a really useful thing. It's going to just throw a random green tube up there, and on either end of that tube is going to be a red dot. So wherever it throws it, if I now grabbed that red dot, I could drag it over and make it connect to right there. And then I could grab this red dot and move it to wherever I want to connect these. All right. You're going to want to make the radius of that tube be 1.5, 2 millimeters, somewhere in that realm. We're going to use several of these, so it's not like it's only a small, tiny piece of resin that's holding this. It'll be supported from buccal, lingual, and in between. And the other thing that you'll want to make sure is while you've got that add tube function open, you need to hit these drop-down boxes and make sure it's set to spline outside. That means it's going to build to the outside of whatever surfaces that you're connecting it to. And I would also suggest that your combine mode, you have the option to do a Boolean combination of the tube and the guide and all that, but I would suggest make it a new object and then combine them all later down the road. So we'll show you that in a moment. So what I'm going to do is I'm going to just over and over use that add tube feature, and you can see what I'm doing is once it throws it up there, I'll drag one end to where it's going to the guide tube, and I'll drag the other end where it's going to the guide. And then once I've done that, I'll spin it around and look from the lingual, and I'll repeat that process. So now I have a buccal and a lingual support. And then finally, I would actually add a tube between each guide tube. And sometimes I'll even do one off the distal and make it connect to like right back here. And that's going to be extremely rigid when you do this. You shouldn't have to worry about this breaking. And then finally, as we did that, we've added what, 8, 9, 10, 11 tubes, and that's what you're seeing, all these new objects. So once I've done this, I can now control select all of this and then combine them into a single file. And now you have your completed drilling guide. So it doesn't take that much time to fabricate in Mesh Mixer, but you just got to be comfortable tinkering around in Mesh Mixer. So with this done, I'm going to export it, and now I'll label that as my drilling guide or osteotomy guide, whatever you want to call it. Okay, open face design, relatively simple to make, exact same shape as your reduction guide, so you should be familiar with how it seats. So this is a really nice method. And, me and Danny tried a bunch of ways, him being the one to do the surgery. And this is pretty much the way that we've come down on as our way that we do it now pretty much all the time. All right. So before we do the last step, which is making the prosthetic, I'll go through questions again. What's your opinion about sleeveless guided surgery and milled versus printed? So for a guide, there's no advantage of a milled guide over a printed guide, and it certainly is going to cost a lot more. So I would probably not mill guides. Sleeveless guided surgery is great, and it's what I generally do. But in order to do that, you've got to be using the portion of the drill that comes in contact with the guide has to be non-cutting. So that could be, let's say if you were using the BioHorizons or Nobel kit, those are keyed systems. And so what always happens is that you're sticking the metal key into the guide, and then the drill's going inside the metal key. So it's redundant to actually use a metal sleeve to stick another metal sleeve into. So what I would do is just measure the outer diameter of that key, and then I would make my guide hole in the software be about 0.1 larger. And that way I can just take the key and stick it straight into the resin printed guide and don't have to worry about shavings. Alternatively, if you were using something like the Blue Sky Bio keyless kit, here again, I don't use metal sleeves because they're unnecessary. The only thing that's contacting the guide is that smooth portion of the drill, the built-in key. Now, if you're using a system where it's just a straight up drill, then yes, you're going to need a metal tube. So it really is dependent on what system you're using. I would like to know if I could be helpful to your practice as an instructor. Please let me know. Okay, thanks, Robert. Do you have a minimum requirement that you would advise for the hardware? So what I usually tell people, and maybe Michael would be the better person, but I usually tell people to get 16 to 32 gigs of RAM. You want a pretty high-end video card, so something like a NVIDIA 1060 or something like that. I would get at least an i7 processor, and a solid state drive is going to be faster than a normal hard drive. Anything you'd add to that, Michael?
I would just say that the RAM on the video card is important as well. You want to get, at least 2 gigabytes of RAM on the video card. Also depends on what kind of user you are. If you're going to be using the software nonstop all day long, and then I'd obviously suggest a more powerful machine, because its amount of time saved in each case will be much more significant, especially for processes that require a lot of processing power, processing time.
Which are segmentation, making, these full arch guides, all that stuff is just a huge memory hog. So absolutely, Michael's right. Try to get, again, a good video card that maybe has 2 to 4 gigs of its own dedicated RAM. But yeah, if you get a computer that fits those, which generally those are your gaming laptops, then it should work really well. Okay, glad I answered your question, Stephen. And yes, I agree. Mesh Mixer, I understand people not wanting to learn Mesh Mixer because it's a confusing program. It's hard to learn, but I do find a lot of uses for it. Our goal going forward is that we're trying over time, and you've seen this if you've been using Blue Sky for any amount of time, that we're continually trying to add features and eliminate the need for Mesh Mixer. But when you get into some of these really crazy cases, I don't think that we'll ever completely eliminate it if you're doing off the wall stuff, because we have to walk the balance between putting so many features and functions into the software that you need a supercomputer to run it, and it becomes so big that it's like Photoshop, where you got to be superhuman to learn all the functions. So that's the line we have to walk. So we're going to try to put all of the most useful features of Mesh Mixer into Blue Sky Plan over time. But, if it's an obscure feature, that's where it's useful to learn Mesh Mixer. Are there any patents on tube guides? I'm not sure if you mean guide tubes, like the little metal tubes. I don't know of any patents on that. MIS has a system. I don't know. I'd have to look into that. I'm not aware of any, but that doesn't mean they don't exist. How can you control the position of the first point of the add tube feature in Mesh Mixer? You can't. It's just going to throw it up there in some random spot. And so you'll just have to go and find that little red dot and drag it. I will just give you a quick little tip. You don't actually have to grab on the red dot. So if I can get back here. So right here, this one's facing us. So this one, obviously I would grab that red dot, but right here, you might be inclined to think you're going to have to rotate it around, and then how am I going to see it? Because it's sitting on the guide. You can actually click through the green and find the red. So if I clicked right here, I would be able to grab it and move it too. So that was one of the learning curve things that I found out that made these tubes a lot easier to manipulate. Now, let me real quickly, I don't have this necessarily in the presentation, but I do have a YouTube video. If you are just not gonna hear of any of this Mesh Mixer business, someone type into the question and answer box, how could you hack the Blue Sky software to connect this guide tube down to this? Can anyone think of a good little hack that would allow you to do that? Bueller. All right, looks like you don't. So one of the things you could do is you could add a custom implant. So Blue Sky Plan, you can add custom implants, and then you could just put those things in and stretch them and make them long enough to where they connect these two and impinge between them. And then when you export all of those little custom implants plus the guide tubes plus the reduction guide, you'll end up with the same net result. But I just find it more tedious to do that and have to position all those little implants. Let's see, would you agree that we can dispense with the lingual flap and with the lingual area so that the lingual flap reduction is not required? Yes, we've certainly done cases like that where we use a buckle only guide. If you're familiar with the Chrome system and with the anatomic guide from Image 360, that's what both of their options do. It's just as easy to do that if you want to, but if you're going to do that, obviously Chrome is using metal, so that gives them plenty of strength. But if you look at the anatomic guide, the only way they get away with that is by making the plastic much, much thicker. And so if you're going to go that route, you're going to probably have to increase your guide thickness so that it doesn't just snap on you because this is only 3 millimeters of plastic. But yes, if you've got enough anatomy on the anterior of their ridge, then yeah, it'll sock right in there. And Danny and I have done some cases like that, and it's great. It does work. If I have my preference, I would have at least a little bit of occlusal extension on the top of the ridge to eliminate the potential of rocking. And if you put just a small lingual flange on this, I don't generally find that that inhibits much. So remember, you can always go back after you print this, and you could use a handpiece and grind down the borders of this to where they're not so aggressive. I mean, this is going way back here. That's probably unnecessary, but you can grind on it as much as you want. And I'll make the point a little later on that you should always, if you're doing these cases yourself, always, always, always print your study mandible or maxilla and do a mock surgery, okay? Because you're gonna get the opportunity to fit these guides on and to really look at it and analyze it. And okay, this is gonna be very difficult to flap that far. Maybe I need to recontour my guide here. It's very worthwhile to do that. Any recommendations for fitting the sleeves on an open face guide? Yes, it's sturdy enough. I'll just say this about fitting sleeves in general. The reason most people have difficulty in putting those in is because they try to do it after they've post-cured. The time when you want to place your sleeves is right after you've taken them out of the alcohol bath, but before you post-cure. Because at that stage, the resin is still somewhat soft and tacky, and you'll be able to kind of force it in. What I use is a Phillips head screwdriver. So I'll get it pushed just a tiny bit into the hole, and then I'll use that Phillips head screwdriver and just hold the guide, and I'll kind of push and rotate. And that gives you a much more centralized point. So you're not, making your finger bleed trying to push that thing in or using your fingernail. So I've not had any experience of difficulty with that, but if you post-cure it first, I can just about guarantee you're going to have to get in here with a diamond burr and open this thing up a little bit before you can get that tube seated. And the other benefit is that, if you're doing it after post-curing, you'll probably have to super glue them. If you fit your tubes prior to curing and then cure it, then as it cures, it's going to harden itself to that tube and there's no need to glue them. So it makes everything easier. I believe less wobble. Would you agree? Your sleeves are great in BSB. I'm not sure what you are referring to on the wobble of whether or not that's, I think you're maybe referring to a buckle only guide. And yes, if you have a buckle only guide, there is more of a tendency to get some wobble, which is why I do like a little bit of occlusal extension, if not a bit of lingual extension also. Is there a hack to avoid possible interruption of the tube and the guide tube? I'm guessing what you're referring to is that. Do you see how when I add this, Mesh Mixer is going to force it to square off the end of the tube? And as a result of that, oftentimes you're going to get a bit of that tube shining through and going into the interior of your surgical guide hole. And so part of the reason I said earlier to do these as separate objects is because I didn't want to bog us down too much and show this, but if I've done this as a separate object, then before I combine everything, I can just go and click on this tube that I added and then run a plane cut and then just cut that excess off. And now it's gone and it's not going to affect me. You could also just print it like this and just use a diamond round burr and just grind those out. I mean, there's not any one way. All of them will work, but The other alternative to doing this is if you go into the preferences setting in Blue Sky Plan, one of the preferences you can change is the guide tube wall thickness. So if you gave this a much thicker wall thickness, then it's going to build to the outside of that and not impinge all the way through to the interior. So if you were to make your guide tube thickness, the wall thickness be 2.5 millimeters, that would become a non-issue. But then the tubes are bigger and you lose a little visibility. There's no right way or wrong way here. Do you have OSTEM settings yet for prosthetics? I don't think they are in there. Do you know, Michael?
I don't think so. You can email us a plan at Blue Sky and we'll check for sure, but I don't think so.
Yeah, I mean, we have a protocol and we can send it to any company and it walks them right through how to do this, but for whatever reason, some companies are averse to doing that. I don't get it, but whatever. Implants, no, we don't have them from OSTEM. So you'd have to just do custom implants or find another brand of implant that's the closest size to that. What kind of 3D printer do you use? And can you give us the parameters when you print the guide? So I counted this yesterday. I have 11 3D printers. But I primarily use my Sprint Ray printers the most, and that's the Moon Ray and the Sprint Ray printer. I actually did just notice that they have dropped the price on the Moon Ray from 4,000-ish down to 2,000. So you might want to look at that. It's an excellent printer. The software is great. Part of why I really like those, one, they've been reliable, but two, the software is just really, really easy. So I like those a lot. But there's plenty of others that work. The Frozens, the Photons, the Form 2, all of those things, they work. They will just work. What really makes the difference to me is build plate size, speed, and ease of use of the software. And that's where I think Sprint Ray is the winner on those. If you don't mind those things, then hey, not a big deal. The parameters I use for the guide are going to be printer dependent. I'll just show you as a quick example here. If I were to open the Sprint Ray software, and let's say that I wanted to print up all of these guides that I've made here. So here is the lower drilling guide and lower bone reduction guide, and the lower prosthetic is somewhere, lower indexed prosthetic. So let's say we were going to print all of these. I wouldn't print these all in the same color, but just for the sake of showing you, we'll do it. So here is the three guides it's importing. And I'll show you why this software is easier to use than most, is because you've got this really clear view of the surgical or of the build plate. And the widget is going to pop up as soon as you hover on it, and you can change the orientation. You could lay it down flat like that to where it will, print faster. Do always, when you print, put the intaglio facing up, because the other thing you've got to do is you've got to support this. So I just go to supports, generate supports. And what you don't want to do is have to clean off all those little pegs where it connected on the intaglio of your guide. Okay, so I would repeat that for all of these. And then it's simply a matter of choosing your resin. So let's say we were going to do surgical guide resin. All right, so here's surgical guide 2 at 100 microns. And then you simply go to print, and it's telling me it's going to fail because I haven't supported these. But again, that's some of the nice features, is it's going to auto support things. It's going to tell you when things are not optimally positioned. It'll automatically fix them. Another cool feature with this one is if you import an intraoral scan, you probably know that an intraoral scan can't just be printed. You have to close it and make it a watertight model. This one will notify you of that, and you just push a button, it bases it, makes it watertight, and builds it where it's going to be printable. So you can see all these guides are going to cost me 37 milliliters of resin, which is not much. You're looking at a $250 bottle that has 1,000 milliliters in it, and this is going to take 53 minutes of time. But again, nice thing here is I don't have to worry about figuring out my print profiles and all that kind of stuff. It's just done automatically. If you go with some of the cheaper printers, you will have to either figure out the profiles for that resin yourself, or find online someone who's done it and then copy those. Okay, I think that was questions. We'll come back here in a little bit later. So these are, this is our final drilling guide. So now we have reduction guide, drilling guide. We're 2/3 of the way home here. Now, for making the prosthesis, you've got a lot of options. You can use ExoCAD, you can use 3Shape, you can use Blue Sky. I'm obviously going to use Blue Sky because that's the one I'm most comfortable with, and that's going to be the one that doesn't have a big upfront cost. So the Blue Sky denture module can actually be used to make this prosthesis, but there's a catch to that. We've actually, we don't want to make a prosthesis right down onto that bone STL. That's not going to work because you've got to have room for your tissue. You don't want a prosthesis sitting directly on bone. So the catch is that we've got to create some space between the jawbone and the underside of the restoration in order to give your tissue a place to reside. And so there's two options for that spacer that I know of. The first one, if you prefer to stay in Blue Sky entirely, is that you could just go in and on that reduced jaw model, you could build a guide. And it just so happens that the default thickness of surgical guides in Blue Sky Plan is 3 millimeters. So if you make a 3 millimeter guide, now we could go and build a denture, let's say, on top of that. And the underside of that denture is going to be 3 millimeters off of the bone. All right, that's option one. Option two, you could use Mesh Mixer to offset the top of that reduced jaw and then build it on that. Now, usually I do this just out of convenience because I'm already in Mesh Mixer from, combining all those tubes. But this is just an example. If we've got this reduced jaw and we're doing it in Blue Sky Plan, we make a 3 millimeter thick guide over this jaw. And then now when you go into denture module, you'll just build the denture or the prosthesis on top of this. Okay. The way I typically do it, again, because if I make the guide like I just described, I'm already in Mesh Mixer. I already have the offset or the reduced jaw right in front of me. And so all I'll do is go up here and use the select tool. And I'm going to highlight the top of the ridge. I don't need to go way down the sides or anything. I probably went too far here. But once I select the entire top of the ridge, I'm going to come up here to edit, and we're going to offset it. And how much are you going to offset it? Well, we're going to offset it by 3 millimeters. So it'll default to whatever the last distance that was used. But if it's not 3 millimeters, change this number to 3 and then hit accept. And this is what it will do. So it just takes that mesh that you highlighted and it like expands it like you're blowing up a balloon. And so it's going to offset it by 3 millimeters. And I'll usually double click on it and also hit smooth just so it's a little bit smoother as well, because the underside of your prosthesis is going to be the exact same as the top of this. Okay. So now I've got this file that just takes a moment to create, and I'm going to save it as an STL. So I go to export and I'm going to name it the reduced jaw offset by 3 millimeters. Remember, I told you, you've got a lot of files here. You got to get specific with your names so that you can find these things and they're all in one centralized location. And now that that's saved, I can just go back into Blue Sky and pull it right into the case. I'm not going to need to stitch it. Remember, it's going to already be in the right orientation. So when that stitching dialog box comes up, just X out of it. And now once it's imported, I'm going to go up to the top and choose the denture module. All right. So now we're in denture module, and you need to start by adding the teeth. So I'll hit the add tooth button. You can choose what library you want. And so in this case, I'm using Dave Vege's teeth. So Dave's a dentist and a lab technician over in the UK. He actually turned his own teeth into a library. So that's what I'm using here. Part of why I like this library on hybrids is because it is a shortened dental arch. If you look real closely, you'll notice he doesn't have any first premolars. My arch is the same way. Our orthodontist apparently didn't care too much about pulling those. So it's a shortened dental arch already. And then I also leave off the second molars. So it's a shortened dental arch. And Dave's teeth, Dave's a big 6'5" bald-headed guy that looks like he, is a linebacker. So they're really masculine looking teeth. Don't use this on a little old lady. It will not fit her. But I'm going to choose first molar to first molar of Dave's teeth, and I'm going to say okay. And then I just hit shift and left click to drop that arch into the case. Now, you need some basis to know where to set the teeth in space, right? And, you know, otherwise you're going to just be purely guessing, and you may have some huge over opened prosthesis. And so we've got these global alignment tools that are going to allow you to position the entire arch of the teeth. But what do we have that we could reference to aid us in setting those teeth? Well, remember, we scanned this patient with an ideal denture and with the teeth where they should be. And so if I just go up here and turn on the patient's lower denture, now I can see where his teeth were on the ideal denture. And I can now just start aligning the teeth in Blue Sky Plan closely to this, okay? So I'm going to try to get the incisal edge position lowered down here to where it coincides. I want the occlusion of the posteriors to coincide. I want the functional cusps, particularly in the same area. This is not the time to go trying to make changes, because remember, the denture was ideal. So you don't need to mess with it and recreate the wheel. So I'm going to align the teeth, and then if the arch form doesn't coincide with the patient's denture, you can turn on the tooth chain. And let's say that the posterior quadrant needed to come out. I could lock this tooth and then just push shift and click and drag the entire posterior quadrant to where they're in the right position. And now that I've got the teeth all positioned correctly, we can make the prosthesis. Now, going back to what I talked about earlier, why is it important to do them in occlusion? This is a case where we did not scan them in full occlusion. So even though I was able to roughly align these, you can imagine the occlusion is not going to be spot on once this patient bites down, right? Because I'm in the same general plane, but the cusp inclinations are not the same. There's going to be differences. Now, if this denture had been taken, or if the scan had been taken with him in full occlusion, then I could go in and use the tooth tools, and I could fine tune it and make that where it is an absolutely perfect occlusion. I just don't have that option here though. So that's why I would suggest that you do that at the desired VDO, because otherwise you'll have a lot more equilibration to do. Alas, here we did not do that. So this is the best we can do. So we're ready to make the prosthesis now. And what you're going to do is simply make a denture. Granted, it's going to be a hybrid denture, but we're just going to make it that by making shorter flanges. So you go to the denture fabrication panel. We're going to create a mandibular denture on the model that has this offset tissue, and I'll push create denture. It's going to lead you through 5 or 6 steps. First one is set your path of insertion. So I just put in what a normal lower denture insertion path would be, and it will build this path of draw model. And now you've got to define your denture borders. So as you know, with a typical denture, you'd be going right down to the depth of the vestibule. I don't want to do that. Here, I just want to stay right on top of the ridge and pretty much make this where there are no flanges. So I've drawn my border just like you would draw a guide. I usually max out the smoothness when I'm doing this, and then you click next, and the software is going to fabricate this. Now you can use the festooning tools. So here I'm using the local deform tool, and these areas where the gingiva is not out far enough, I can drag that out. I can expand it. If you look at the lingual, obviously that is too thin back here. And so I want to bulk that up quite a bit. I would rather have my gingiva on a printed hybrid be over bulky rather than under bulky, because it's going to give it more strength. If you decide to put some type of reinforcement on it or in it, it's going to give you more room to house that. It's just going to make it a lot stronger overall. So I'm going to stretch that out. And now you see how much more bulky this is. And essentially we've created a hybrid here. It doesn't have holes yet, but we've created a hybrid that sits 3 millimeters off the bone, has virtually no flanges to adjust off, and we'll be able to convert this into a bone indexed prosthesis. So I click next, and as the last step, the software is going to create sockets. So if you want to get fancy and print the teeth in white or mill them in white and then gingiva in pink, you can do that. Generally, I don't bother with that. I'm just going to print this as a monolithic chunk. and then I'll print that in white and then add some gingival composite, or actually I use Triad high flow, and that applies very quickly, and you can add that to the front to give it the aesthetics that you're needing to put the pink on. So if you're going to do a monolithic denture, you don't want the denture base that has the sockets. That one is going to be labeled denture-fin for final, right? So you see the sockets that are over here. Rather, if we're doing a monolithic denture, then I want to export the one that's just labeled denture base, which means it will have no sockets, and I'll export all of those teeth simultaneously. All right, so now I go and export these, and I'm going to name it in that patient's folder, the lower prosthetic. All right, so home stretch here. Last thing in Mesh Mixer is we've still got this, this case opened from earlier. So I'm going to come and import now that lower prosthesis. All right, and when I pull it in, notice that now this is a monolithic denture. It's a uniform 3 millimeters off of the bone, which is just about the perfect amount of space for the tissue. And we just need to find some way of indexing this in the mouth into this position, because obviously it's floating up here. If you try to hand pick this up, very high likelihood you'll overseat it or underseat it or introduce some canting, something like that. And so it's better if we can create some sort of indexing mechanism. So just to let you think for a second, what do you have that you've already made that would allow you to index off of the bone? Well, you have that reduction guide, remember? So if I just imported that, well, actually, I'll come back to that. The first thing we need to do is make some holes. Okay, so we need the pickup holes for the prosthetic. And we can do that by just adding some abutments to the implants. So I want these holes basically exactly where this gray line is extending out. So what I'm going to do is right click on the implant and say add an abutment, or if you've already got one on there, you can say replace abutment. But I'm going to make that 20 millimeters long. I want it long enough that it extends all the way out of the prosthesis. And then your diameter is going to be whatever size you want that pickup hole to be. Okay. So in this case, I made a 7 millimeter one since those implants were slightly divergent. If they were perfectly parallel, I'd probably do a 5 millimeter pickup hole. But now you can see this is where I would like the pickup holes to be. And so we did add Boolean functions in Blue Sky, but as of right now, you couldn't Boolean like an abutment from a denture. Okay, so instead, I'm just going to go into Mesh Mixer. And what I need to do is export these 4 abutments. All right, so go to export, just check on those 4 abutments and nothing else. Label it as 7 millimeter abutments for such and such patient. Okay, and when I pull those into Mesh Mixer now, I have my prosthesis, I have my abutments, and if I can simply Boolean subtract these abutments from the prosthesis, there we go, I have my pickup holes. All right, so we can do that. A quick little tidbit of advice. This frustrated me forever because a lot of times I would try to do this and I would maybe try to subtract all 4 of them at once, and Mesh Mixer would sit there and it would run for 2 days if I let it and never do it. The reason is the geometries here are too complex and there's too many face groups. If you think back to what face groups were earlier, right now for the abutments, we have 1 STL, but made up of these 4 face groups. On the denture, we have 1 STL, but it's made up of 1, 2, 3, 4, 5, 6, 12 face groups. That's a very difficult, complex geometry for it to subtract from. So the simple fix is, before you try to do any Booleans, is to first go make your abutment solid. So I can go over here, hit make solid. And again, it degrades the quality ever so slightly. You see the edges get rounded over here, but for our purposes, that's perfectly fine. So I'm not even going to mess with the accuracy here. And then you would also want to make solid the prosthesis, where it's not a bunch of face groups, but rather now it's all one continuous group. Okay, so now that I have the abutment solid and the denture solid, it becomes really easy. You can, in your objects browser, you want to control select first the object you're wanting to subtract from, in our case, this denture, and then control select the object you want to subtract. So the second one would be the abutments. So once you select two objects like this, this menu will come up and you'll see the option of Boolean difference. And we're going to choose that. And here's what happens is it's just going to subtract those out. And now we have pickup holes. All right, so this is where I jumped the gun a minute ago. We've got this thing, it's got pickup holes, it's sitting off the gingiva, but it's floating. So how do we make that index? I'm going to do it by using that bone reduction guide that we had earlier. So essentially, you've got the bone reduction guide as part of all three of the guides in this system. And to me, that's a big advantage because it means they all fit the exact same way. So once you've figured out the fit of one, all the others are going to see it the same way. So I'm going to pull in that reduction guide. And now we got to find a way to connect them because they're still not touching. So how would you do that? Well, you could use implants in Blue Sky, but I'm going to just use that same add tube feature. All right. So before you can add a tube, you've got to combine these two files. Remember, right now, this is an STL and this is an STL. So I'm going to control select both, combine them, because you can only add a tube to one total STL. All right. So now these are saved as a single STL. And I'm going to do all the same settings for the add tube that I did earlier. And I usually will do a tube right off the distal on each side, one in the middle, and then I'll do 3 in the front. All right. Now this is a single STL, and what it allows you to do is index this into place. It's going to position your prosthesis in the exact position it needs to be in, where it's sitting up off the bone. You're not going to introduce any canting. You're not going to seat it too deep or not deep enough. It's just going to make this a lot more dummy proof. And this is the final guides that you need. So now you have all three components for the swappable guide system. You've got the reduction guide, the drilling guide, and the indexed prosthesis. So congratulations, you just saved yourself a few $1,000s. Again, there is a learning curve for sure on this. A case like this for me nowadays takes per arch 45 minutes or so, but the first 3 you do, they'll take you a full day. I mean, you're going to be so frustrated because you just got to get the sequence in mind and what do I do next, all of those things. But I promise you, if you'll stick with it, eventually it kind of becomes second nature and you can buzz through these things pretty quick. So this is the final result. And we could print those, and I definitely recommend printing 2 each of the guides. It's just a little resin, but that way you have them in case it breaks. One disadvantage to printed guides over instead of metal is obviously that they're not near as strong. So if you break one trying to fit it in, or the assistant drops it or whatever, you got to back up, right? If you don't do that, you're kind of up a creek. I mean, you got to abandon doing it guided at that point. But the other thing I would really suggest is that you print the jaw, the unreduced jaw, the original segmentation, and use it to do a mock surgery. And another little tip, I mean, if you're just drilling into a fully 3D printed model, you'll beat your drills up pretty bad. Something I've been doing is I'll take this object of this jaw and I'll use Mesh Mixer and hollow it with just a 0.5 millimeter of wall thickness. So basically you have a 0.5 millimeter of printed resin and then it's hollow all the way through the rest of this. And then I actually use some foam. Forgetting the type of foam, but I could let you know, but it's 2 components. You just mix them up and then I'll create a hole in one side and then pour it. And I fill this whole model full of solid foam, which is great because it cuts a lot like natural bone does. It's a lot softer than printing resin. It's not going to damage your drills. And it's going to give you a pretty realistic surgery. It's kind of like you got a cortex and then you get down into the cancellous bone. And you'll see an example of that model here in a moment. But print all this stuff because you definitely want to practice fitting your guides on this model, if not doing the full surgery on the model prior to trying to do it on the patient, okay? So these are some beautiful cell phone pictures I took this morning, but this is that same case, okay? So you see the reduction guide, you flap them down to their liver. Notice that I'm avoiding all the anatomic structures. I've ground out a little bit to give it some more room there. And this has a really definitive seating position. So I seat this completely, and with it fully seated, now I'll drill the pinholes. So I'll take that 2.2 drill and I'll run it through each of these front holes. And every time I drill a hole, I'll immediately follow it with a pin, and that way it's pinned into place. And once it's pinned into place, that frees my hands up, and now I don't have to spend my effort just securing the guide and holding it down. All right. So this is an example of that model. You can see the white foam up inside of this. So this is after that reduction has been done. So we've reduced the bone. And now that the reduction is done, we can pull the pins, get rid of this guide, and put on the drilling guide. And the drilling guide is going to fit the exact same way. The pinholes go into the same spot. Notice that I don't have any metal guide sleeves because I'm using the Blue Sky keyless kit. So there's not a need for it, since that's non-cutting on the part that engages here. And so you would want to now do your osteotomies according to whatever the kit is that you're using. Here you see a 3.1 millimeter drill going in place there. But notice that this guiding section is all smooth. There's nothing sharp or cutting on that. So it would be redundant, and actually it would be less accurate if you were to use a metal sleeve, because it's just one more layer of slop and inaccuracy between two surfaces. So I'm just going to go around and do the drilling protocol in all the sites. And once that's done, you're ready to place the implants. And so, since again, I'm using the Blue Sky fully guided kit, I can fully guide the implants into place, and using the ratchet with the guided driver. And this is a Biomax 4.3 by 10 or 11, I think. And we're going to crank that in, and you crank until the stopper here bottoms out on the guide tube. And the moment it does, you got to quit cranking. Because if you keep cranking once that bottoms out, one of two things is going to happen. The implant is going to continue going deeper, and it's going to break the guide, and it's going to be very difficult to get off. Or the more likely scenario is the guide is going to hold up, and as you keep turning, it can't get any deeper, and now you've turned it into an auger, and you're just going to end up stripping your osteotomy and having no stability to do immediate load with. All right, so do this with all your implants, and you can see, granted this is a tabletop surgery, but you can see how accurate everything is, and there's no reason that it shouldn't be just as accurate if you're doing it in the mouth, as long as you're seating your guides fully and following the protocol. So now you can remove the guide, and you can see my implants all in place here. They're a couple millimeters subcrestal, just like they were planned. Another nice thing with that Blue Sky fully guided kit is that the initial drill is a bone profiler, and so it's going to profile out an area big enough so that you can get a multi-unit on. Otherwise, if you didn't do that and you placed them subcrestal, you're going to have to go and do some profiling before those things will seat. So now I can put on the multi-units, and again, here I use straight multi-units. They're not perfectly parallel, but they're pretty parallel. They're within 10 degrees of one another. And these are just so much easier to place because you simply grab the driver and they just screw on. There's no timing to worry about, nothing. So I'm going to just screw these things on. If you were using angled multi-units, then when we're back here at this step, you're going to need to dial in the timing. Okay, so this driver has 6 marks on it that correspond to the flats of the implant, the hex inside of it. And so you would probably need to create ahead of time an indexing notch on the guide and then align one of those notches to this, okay? But since I didn't use those, I'm just using straight multis, and then these are the temporary cylinders that we sell. And notice I'm using the long screws. Obviously you couldn't screw the restoration down with this, but these are great for the pickup, because you're not going to have to worry about filling your screw access hole with Teflon or a Q-tip or a micro brush to keep it from getting filled with acrylic. These long screws will maintain that space. And so here is the restoration indexed into place. Again, I know it's in the right place because I pinned it in. I know that's a terribly dirty print. I didn't rinse that very good, but it's gray anyway, so give me a break. And you can see here on the pickup, look how in the dead center of these holes is where those implants are emerging, exactly where we planned them. And so, man, this just removes so much guesswork during surgery because everything is right where you planned it. You know it's going to be ideal for the prosthesis. You know that that prosthesis mimics what the ideal teeth were from the denture. You can't just isolate any one step out of this and mimic that and expect to get the same result. You kind of got to follow the whole system, otherwise it all breaks down. All right, so pretty much there. Let's see the questions. What kind of printer to use? Again, I think I answered that one. I think the guide you made with mesh mixer is the same as the first one you did before you cut it for bone reduction. Am I wrong? Yes, because if you remember back to that guide, it built the full thickness and you didn't have any visibility when you did that. And that was why I prefer that open face design. Are they still trying to get you on guides? Everybody's always trying to get me on something. Let's see. I think you'll always use mesh mixer, probably if you're doing a really complex one like this. Someone knew the answer back here about the implant to connect things. I mean, using guide tubes to create guides in mesh mixer. Oh, the M guide. Yeah, I've seen that. And I mean, it kind of looks cool, but it would be very tedious to make in mesh mixer that way. And you've still got to come up with the guide tube and you've still got to have the CT planning software. So I wouldn't bother with that. It's kind of a solution to a problem I don't have. Farley has a great mesh mixer tutorial. Yeah, Nate's great. He's got a lot of good information. Michael Scherer has some information on learning to use mesh mixer. I'm working on some, but just got too many things going. What about the inner part of the hole? Yeah, we talked about that. You can either grind that out or you can cut that prior to exporting it. What resin would you print these with? I would print the guides with surgical guide resin. The prosthesis, this thing, I would print in whatever the strongest crown and bridge tooth colored resin I could find. So I think right now in the States, that's crown and bridge MFH. I will say that with a purely printed prosthetic, if it has no reinforcement in it, it's very prone to breaking. And so we've addressed that with numerous ways. I've got videos up of how you can incorporate a tri-lower arch bar. You could incorporate a fiberglass mesh on the back side of it and just cover it in resin. That adds a ton of strength. You could incorporate paper clips. I mean, there's so many things that you could embed inside of that resin. Just cut yourself a channel or do it in mesh mixer and then put that piece of metal or fiberglass or whatever in there and then resin over it, and that will make it much, much stronger. But if you just use the printed one, there's a high likelihood of it breaking. So buyer beware there. Isn't having those sleeves that tall decrease the accuracy? I think maybe you're referring to these tall screws. I'm not entirely sure. As far as where the sleeves were back here, remember that's only about 2 millimeters of space off of this. So that's actually less space than what you would typically have on a normal tooth-borne guide. So yeah, I don't worry at all about the accuracy of that. If you're referring to these long screws, some people have looked at those long screws and said, well, you can't bite them down to position it. Well, we're eliminating the need to bite down because our base here is indexing it way more precisely than we could ever do by hand and manipulating the patient into their full bite. Check settings on the printer used as accuracy and tolerance can be altered. Yeah, you can alter that on most printers. You need to offer more courses. You have too much information. Well, yeah, that gum COVID thing got me, but I'm trying to get those things going again. Will this be available for viewing? Yes, it will be on YouTube probably within an hour or two. I love Moonray S, but thinking of Pro, yeah, I agree. Pro is great. It's double the print's build plate and double the speed, but not everyone needs that speed. I would say if you're doing lots and lots of models, or if you're doing lots of clear aligners, probably makes sense for the Pro. If you're the average GP that's doing a guide here and there, maybe a denture here and there, I still think the Moonray is an excellent buy. It is not showing in the screen sharing. I hope that wasn't going for too long. All right, so apparently we had some technical difficulties at some point. The resin to print a bone model, any resin that you want to. I'd use whatever's the cheapest. BSP denture model is great, but he likes exocad better. That's true, but exocad is also $5,000 to $10,000 upfront cost, and it's a lot more difficult to use or learn, at least in my opinion. For me, I can crank out a denture on the denture module a lot faster. So that probably just comes down to comfort level for the individual and what they're used to or what you learned on. Can you explain how to remove excess from the tube in the hole? Yeah, that you could just drill it out, or you can plane cut those, because remember, those tubes are individual objects up until the point where you combine them all. Dave is the bomb. Yes, he's the bomb. Yeah, he does look like Vin Diesel's twin. Do you use the mesh mixer magnet tool? Yes, on occasion, like if I'm trying to create a tissue stop, but not really in guide fabrication. I don't use that much. Can I use Lab Pronto to design my bone reduction guide and drilling guide? Now, a quick disclaimer, I don't know for sure if Lab Pronto is going to design them the exact same way as what I'm showing here. So that is something you might have to clarify with the individual lab, or if there is a particular lab that does this workflow, you can specially request a particular lab through Lab Pronto. So import the reduction guide and the implant. I'm assuming you're talking about for making pickup holes, and for that you just need the denture and the abutment, and that will be subtracted to make the pickup hole. Again, timing, if you're using straight multis, becomes irrelevant, but if you're using angled multi-units, yes, you have to dial in your timing perfectly. Some people will do that by creating notches in their guides. Others are content to just sit there and, you know, rotate the implant 5 degrees and try it and see if it lines up. That's up to you, but I do have a video on my YouTube channel of how to control the timing on guided surgery. How do you position the STLs for printing? Pretty much my only parameter is intaglio facing up. And then beyond that, I'm just going to position them where they are the flattest possible so that they're less height, and that will make them print faster. Can I make an index prosthetic stackable? You certainly can. I'm not teaching you though. Yeah, it's not rocket science, but again, I'm not teaching it just for reasons of patents and all that fun stuff. Are BSB implants available in UK? Yes, from Implasky, all one word. Do you think it's fine to use the BSB keyless kit and then place Nobel implants? Yeah, I mean, I always tell people in courses, you know, at the end of the day, a hole's a hole. The body doesn't know whose drill made it. It doesn't know whose titanium you're screwing into it. What's important is that the hole be the correct size. So all that we're after with the guided kit is making very precise holes in the right trajectory, depth, and dimensions. So because the Blue Sky Biomax is compatible to the Nobel Active, and I think they're replace, at least as far as implant sizes, then absolutely you can use our kit. And I would suggest it because, again, Nobel's a great company, but their guided kit is not the greatest. It's a keyed system. It's very expensive. There's a lot of advantages to a keyless system like what ours is. And then you can screw whoever's titanium into the hole that you want. All that you're giving up is the ability to fully guide the implant placement. So you'll be basically removing the guide and freehanding those implants into the hole. Not a huge deal. If you use a custom fixation pin, should the diameter of the pin tube be the same as the pin or more? I would make them the same, and by doing so, you're probably going to have to use a mallet or something to tap those pins in, but you want those pins tight. So that's fine. So yeah, for our pins, they're 2-2, and we use a 2-2 drill, and that seems to work great. How do you prevent picking up the bone reduction guide portion of the immediate load when you're loading the temporary cylinders? So maybe I didn't make this clear, but the goal here is that when you're at this stage, now that everything is indexed, you can now just take your acrylic and squirt in here between the cylinder and the prosthetic. And you're not trying to fill this to the brim, because if you put tons and tons of acrylic in there, it's going to run down all over the bone and possibly lock things in. We don't want that. We want enough acrylic to lock the cylinder to this. And then once that hardens, we undo the screw and we take this whole complex out of the mouth, because now that your cylinders are in there, they're fixed. And now you can just cut off these tiny, what I call sacrificial supports. So use a handpiece and buzz through there, there, and there. And now the prosthesis falls loose, and it's already got the tubes built into it. And all that you have to do now is salt and pepper the acrylic and fill any voids, and then swap out these long screws for the short screws, and you're ready to deliver that prosthesis. So it's really easy. It's actually a lot easier than the traditional pickup methods, in my opinion. But yeah, this is just for indexing, and once you've locked the acrylic to it, then that gets cut off and it goes away. Will this be able to watch again? Yes. Are you working on a hands-on? Yes, I am working on that as well. Would you take this as a pickup to allow you to lose some further visits and act as a verification guide? You could. I know there are people that their verification guide is essentially that they take this prosthesis and there will be some tissue gaps develop. And so all they do is they just basically inject a bunch of PVS on the underside of this and then pick up in an impression this prosthesis. And then you can go to the bottom and attach multi-unit analogs to this. It would not be my preferred way. I would prefer it at the end to do a true open tray impression where I locked all of the cylinders together with a rigid piece of metal and all that kind of stuff. But it's up to you. What printer resolution? I do 100 almost 100% of the time. Trilor is very easy and never breaks. I would agree. How is Formlabs tooth resin B1 for these printed dentures? I can't say that I've used Formlabs, but I would imagine it's going to be extremely close to NextDent Crown and Bridge NextDent Crown and Bridge, Sprint Race Crown and Bridge, Sprint Ray Tri-End. There's a bunch of those resins, and they're all super similar in mechanical properties. But the MFH is significantly stronger. But bottom line, regardless of which one it is, even if it is MFH, I would still suggest that you put in some kind of reinforcement, even if that's just a fiberglass reinforcement strip on the back side of this, or a metal strip. Danny oftentimes uses that. It's a material called Perf Grid, and it's just a metal strip with a lot of perforations that you can lock to this thing, and it adds a lot of strength. For that matter, you could even go use one of those metal interproximal strips. You're going to embed the whole thing in resin, and so it's safe for use in the mouth, obviously, and you could use that to add some strength. How many models do you have to export in BSB for printing by this protocol? Well, you export in and out a bunch of times. I haven't counted them, but it's a lot, and you end up with a lot of STL files. But also remember, Blue Sky Plan isn't charging you per export. It's charging you per case. So you're going to have the cost to export the first surgical guide, and after that, all the other exports are not going to be charged to you. Do you have a written step-by-step instruction guide for this? Basically, this presentation that I've put together has the step-by-step, and then I've also got those supplemental videos, plus this will be on video. So I can send anyone this presentation that wants it. If you will email me at cglenn@blueskybio.com. Also, can I get a prosthetic made out of PMMA and not resin? So the answer is kind of, but it depends on the shape of it. If you look at the shape of this, that geometry is far too complex to mill. About the only way you'll make this is with 3D printing, okay? Now, there's different ways that I've shown where you could create a PMMA milled one and then have a cradle that it indexes into. I've got a video on that. And it certainly will be stronger if you've got it made out of PMMA. Can I use Lab Pronto? Yes, you can use Lab Pronto. Do you and Danny use a rubber dam when doing the pickup, or just a small amount of flowable? Yeah, we're usually using just acrylic and not worrying about injecting too much, because if you inject too much and it flows down here and then comes around the edge of that multi, you're going to have a lock-in and it's going to be a bad day. So it's not a bad idea to use a rubber dam. You know, if you put that on here, you could maybe squirt more acrylic without worry about that, but it's not a huge deal. Now, I promised you at the end that I would talk about sutures. And so this is a quick case. This is one we did at Danny's course in front of a whole bunch of people. And this case took 1 hour from the start of it until the patient was sutured up and finished. So we did a lower arch with a bunch of extractions and guided implant placement and then pickup and conversion in an hour, which is unbelievable. We could have never done that before non-guided. But we've segmented the jaw. Danny had to go in and surgically remove all of that that blade implant and all that fun stuff. But here is the reduction guide. That should look familiar. Again, it's just, it's got the pinholes and all of this is going to get whacked. That's what the jaw will look like after reduction. And now we have these files available to us. This is our open face guide design. Now on this one, I used the other method purely within Blue Sky Plan. So what these little connectors are is not the tubes, but these are custom implants. And I just tried to make them long enough where they would connect the tube down to the guide and then printed them all together. And that will do the same thing. But for me, it's a little slower. So here's our 2 guides. We did not do an indexed prosthesis here, although we would have liked to because it was a referral patient and the dentist had already made a denture. So we used that. You're seeing here that I'm not using any sleeves. It just goes straight through with the Blue Sky kit. And here's Danny's surgery. So he's going to pluck out all these teeth. The blade implant put up a pretty good fight and he had to do some digging to get that out. But that was placed by his uncle 30 years ago. So that is a pretty good lifespan out of that. And then here's the setup. A quick note, when you do these cases clinically, there is so many little parts and pieces and screws and abutments, and you need a variety of them, a whole assortment. So I would suggest doing as Danny has done here and getting a little tackle box to organize everything. You can make a label maker and that way everything stays in the right spot. Here is the jaw prior to any reduction. And if I remember correctly, he had to extend this incision a lot farther back. You can see the mental framing right there. And now the bone reduction guide is on. So we're going to take down all of that bone. You could use rongeurs. You can use a big burr. It's up to you. You could use a diamond or a nail head diamond or a Lindemann burr. But the point is you want to just grind this down and make it flush with the edges of this guide. And now you see the reduced jaw. Now I should jump back here. We didn't see this until the pictures, but do you notice how this guide was not fully seated back here? So the bone reduction is a tiny bit off. And if we had gone with the other guide design, it would have not seated fully. It probably wouldn't have made a huge difference, but it wouldn't have seated completely. Whereas with this guide design, it doesn't really matter. You know, there's nothing, even if that bone's up a little tall, it doesn't affect the sit of this. So now the osteotomies are being done, and Danny will usually put 1 drill on and he'll do the osteotomy for all 4, and then he'll switch to his next drill and do all 4. And that way you cut down on switching of burrs. And now this is the implant being placed in, and he's going to crank it in until that bottoms out on the guide. So again, just like on my model-based surgery, you can see the clinical outcome. They are dead center of where they're supposed to be. And then the straight multis go on. This is another case where we positioned it both ways and there was no advantage to disto-angulating. So if there's no advantage, I'm not doing it. Here's all his parts and pieces. Implants had 50 or something Newton centimeters of torque, so they were good to go. And this is the denture her dentist had made her. And so when you're doing this, this is a traditional pickup. This is not as precise, but this is how, honestly, most people still do it. So first you need to know where to make the holes. Use some fit checker or PVS, and on the underside, you'll be able to see where those are emerging. Take a big drill and just grind all the way through. So I was doing that in the lab for him while he was putting on his cylinders and getting everything tightened down. And now that we have those holes, which we had to actually manually make instead of already having them ready, now he's ready to do the pickup. All right, so I should point out, do you notice here that there is no suturing done yet? So this is something we're actually working on publishing right now. It's called the full arch healing abutment technique. And again, this sounds crazy, but I've just seen it work case and case and case. I mean, it's crazy. You get more keratinized gingiva, you get a better outcome. It's just better all the way around. So Danny will not suture whatsoever until he has screwed down the final restoration. Okay. And then he's not going to try to tightly suture it in primary closure. He's just going to try to gently snug it up to the edge of the prosthesis. So we're not suturing tissue to tissue edge. We're going to suture tissue to the prosthetic. And essentially, if you think about that, if you do on a single tooth implant, you know, you lay your flap, you put a healing abutment on, and then you're not trying to get primary closure. You just snug it up to the tissue, and that allows you to gain some keratinized gingiva. Well, we're just doing the same thing here on a much broader scale. So this denture is being held in place just by hand, which again, is not as precise, and he's squirting in the fast set acrylic. We did all 4 of them at once and let that set up. And once it was hard, he undid the screws. We took this out. You've really got to, if you're going to do it this way, bite them into occlusion and make sure it's all lined up correctly. And then once that is hard, he takes it out of the mouth, and Danny was, I took it to the lab and did the conversion while Danny is back in the operatory working on the patient and getting them ready to suture and placing PRF and all that. So to do the conversion, this is old school. We had to cut down the flanges because you do not want flanges or any concave surfaces on the bottom of a prosthesis. Please don't do that. It's a terrible idea. I also cut off on immediate load. We don't do more than 1 tooth distal to the last implant for the cantilever. Now, once these are integrated, fine, you can go back to second molars, but not yet. We want to minimize cantilevers during the healing period. And so I'm removing flanges, and then I'm taking acrylic and I'm salt and peppering into any of those gaps or voids on both the intaglio and the top side. And this is what you want that to look like at the end. No concavities, nice and smooth, and now it's ready to deliver. And so you'll notice here that Danny's usual protocol is to draw a bunch of blood prior to the procedure. He's going to turn a bunch of that into PRF membranes, usually 2 membranes per implant. And he's also added some bone grafting on the buccal or lingual, anywhere where the bone was a bit thin or deficient. And so now he's placing his PRF. Oftentimes he'll even cut a hole in the center of a PRF and drape it on here. And once he gets all that done, still no sutures, now he's going to screw the prosthesis down. Now, by doing that, remember that 3 millimeter gap between the prosthesis and the bone? By doing that, he is sandwiching that prosthesis down onto the PRF, and he's essentially filling that whole gap with a ton of fibrin. And fibrin is what your body is going to use in the healing process and eventually turn to tissue, right? So he's given it a huge head start. And only now, after this is fully delivered, will he take his suture. And he usually just goes 1 suture here, 1 suture here. And he does it kind of like a coronally positioned flap in perio. He's suturing the tissue edges up to the sides of this restoration, not underneath this. By doing that, what he's going to gain is mountains of keratinized gingiva. I didn't include it in this, but I could show you lots of post-ops proving that. But it's a really interesting technique. It works extremely well. And again, we'll be publishing that pretty soon here. So that's all I got. Any questions? Got a couple. Is there a way to get individual private training for a case like this? It depends on what I got going. A lot of times for me, it's difficult just because of other obligations, but email me and maybe I can give you some suggestions. A PRF over the bone, where does when he does the no suture technique? Not always, but usually. So anytime he can get PRF, then yes, he's going to put it in there. So I think that's all the questions I'm seeing. Anything else from you, Michael?
We have a lot of comments coming in from the chat box, just
okay.
thanking you for your presentation and their appreciation and congrats and another amazing presentation. So Cory,
good, thank you and appreciate everyone listening.
And we're going to be publicizing a paid remote live course for Cory in the next couple of days. It's going to be, I think, a total option of 8 CE credits, very reasonably priced. Details will be coming out via email, so look for those. And of course, it's highly, highly recommended. It's being limited to a handful of spots. Everything's going to be, it's going to be face-to-face. You're going to be able to hear Cory, see Cory. He'll be able to see you and hear you. It's not going to be the same format as a webinar presentation, but it's going to be much more face-to-face. Everybody could talk freely, interact with each other, et cetera, et cetera. So look out for that coming out in your email in the next few days.
Yeah, because of the COVID thing and the hamper it's put on in-person courses, we're going to give this a try. And granted, it won't be the same as a in-person course, but we're going to try to make it as close to that as possible. You can ask questions during it. We'll actually have audio turned on, so hopefully it's kind of like you're seeing everyone. You can listen to them. But what I'm going to do is there's going to be an option for the lecture only. And then that's going to be 5 hours. And then there's an optional 3-hour hands-on. And so if you opt for that, I'll send you all the models. We'll send you the drills and implants and everything, and you'll actually get to do a mock case. So the first one is going to be May 15th. That's going to be on overdentures, and the course is going to consist of the planning and the software and the clinical steps to make 3D dentures, so using Blue Sky Plan or whatever to make the dentures, and then also how to plan implants in Blue Sky Plan to do overdenture surgical guides. And so the hands-on exercises, you'll actually have the patient that we worked on, you'll have their model, you'll have the guides sent to you and the drills, and you'll actually get the implants and actually place those and then pick up the locator style housings inside of that denture. So it's going to be very affordable since it's the first time we're trying this. Lecture, I think, is $300, and then the hands-on is $350, which is mostly materials, so I'm not making a ton on that. But the hands-on will be limited to 15, and the lecture, just however many want to do it. So there will be a bunch more of those courses, depending on how long this COVID thing goes. And, that may become the new way courses are done. We'll see. But like Michael said, there's going to be information on that going out by email pretty soon.
Yep, exactly. So look out in your email, and it is limited. There are a limited amount of spots for the hands-on. So sign up and grab your spot quickly. Just to repeat regarding the CE credit, since we're always asked several times, if you watch this live, you'll get the CE credit sent directly to your email. If you're watching the recording, then complete the 10-question multiple choice test, and we'll be able to send that out to you. I think that pretty much wraps it up. So Cory, thank you again for your time and all the education that you disperse. And everybody, thanks for attending, and we hope to see you at future courses. Thank you very much.
All right. Thanks, everyone.